I want to start with this Latin phrase, and I'm going to let the computer read it for you.
Per potentiam plurimorum hanc Societatem ad Progressum Artis et Scientiae Chirurgiae constituimus.
And what I want you to understand, everybody of you, we have lots of societies. Why do we need another one? Why yet another society in the spine? I mean, each of you are probably member of 5 or 6 of them. But I want to tell you that there are issues that are not being addressed that this society need to take ownership of. Let's start that our society is getting old, and the rest of the world are catching up with us. And probably within our lifetime, we have a lot of people, elderly people who have spine problems that need taking care of. This is the statistic. By the time you are 70 years old, there's only 1 to 2% you don't have spine problem. Obviously, not all of them need surgery, and not all of them, even if they need surgery, they need a fusion. But that number is increasing. How much is that number increasing is this slide. Spine is number 1 for disability. Disability meaning people cannot take care of themselves, and that is a huge cost to the society. But as a matter of fact, Medicare data is very clear. Literally, about 80%, 70 to 80% of the money Medicare spend on people is in the last 6 to 9 months of their life to make sure they die with dignity. Because these people are not mobile, they are not able to take care of themselves, and many of them, the reason for that is spine. Many of these patients come to me. They go to 5 other surgeons, and they're told, you have a problem, but we cannot take care of you. And then they become immobile, need 5 people to take care of them. And this is from Becker Spine. According to them, 1.62 million instrumented spinal fusions are performed in the United States annually. And these are the patients that we can take care of. So spine, immobility from the spine, disability from the spine is a public health issue. And the reason we exist is because other societies are not addressing this new technology that can take care of a lot of patients that current technologies and societies, they don't address. They don't provide training, education to take care of them. And I think that is our now goal here, to make sure that these issues are addressed. Now, I'm going to talk later about some of the other things, but I want to stop actually here and say that everything we do is about the risk versus benefit. Trans-Kambin approach is not going to make it go away the other ways of doing surgery. That's not the goal. It's not a hammer that fixes everything, but it's a hammer that if you don't have it in your toolkit, you're going to miss a lot of patients that you could help, because by reducing the risk associated with the surgery, we can help a lot of patients who otherwise we couldn't help. So, and the goal at the end of the day is to be able to shift many of these cases to surgery center, and many of those cases that couldn't be done until now, we should be able to do in the future. This is a 1 day of work I do here. I just did these surgeries a few months ago, 7 fusion in 1 day. Every single patient went home within 23 hours. And I go around and I talk to people that this is not specific to me. Dr. Gasco, Dr. Varun Agrawal, everybody who used this technology perform at the same level. So, Dr. Farha, I want to pass the baton to you now. Please introduce yourself, and then we can keep on with the rest of the meeting. Dr. Anjum?
Hello, welcome all. Sorry, my mic was mute. So, welcome you all to the Kambin Symposium. And it is organized by all the participants who are really working in the Kambin Society and who are really devoted soul to progress of the Kambin procedure. So we divided our webinar in one or two parts that I will just introduce our presenter now, and I will request everyone to just mute your microphone for our easy discussion. So I would like to introduce now Dr. Amir Sharif, who is the Board of Orthopedic and Trauma Surgeon Consultant in Germany. And he will talk about the historical perspective of Kambin procedure.
Hi, everyone. Yeah.
Before everyone's talk, if you have sent us your bio, I will quickly put it online for you. Please, Dr. Sharif, the floor is yours.
So hi, everyone. As the colleague already introduced me, my name is Amir Sharif, and it's my pleasure to have you guys, your colleagues today, and I'm going to talk about the historical perspective on Dr. Parviz Kambin. So I'm board certified for orthopedic and trauma surgery in Germany, and I'm working as a consultant spine surgeon there. So Dr. Parviz Kambin, he was a pioneer in a minimal invasive spine surgery. He was born in Tehran, Iran, and then in Tehran University Faculty of Medicine. He has done his medical student time, and then his orthopedic training was in United States University of New York, and after that as a professor and chair in University College of Medicine in Philadelphia. So Dr. Parviz Kambin revolutionized the spine surgery, especially in minimal invasive spine surgery, with describing the Kambin triangle, a technique and approach which minimized tissue damage and reduced the recovery time, which is used in minimally invasive spine surgeries and also endoscopic surgeries. And many professionals, they got lots of influence from his work. Unfortunately, he passed away in 2020, and but his novelty and mission in minimally invasive spine surgery is moving forward, and because of that, today we sit here together. So we have the mission statement for the Kambin Society, which is dedicated to advancing the global standard of spine care by fostering open dialogues and complex cases, and sharing our insights from failures and success, and promoting collaboration across disciplines. The mentorship and commitments with the mentorships that are commitment to training for the hybrid generations from neurosurgeons and orthopedic surgeons that they do a spine surgery, it should ensure the optimal patient care and patient outcomes. We have also a vision statement to build a global community where spine specialists, they can exchange their knowledge, innovate surgical techniques, and embrace a multidisciplinary approach to shape the future of spine care by cultivating a culture of learning, collaboration, and mentorship. So if I want to have a short look to the anatomy that Dr. Kambin described for us, the Kambin's triangle, which is between the transverse process in the bottom, and then in the posterior side of that is the articular process of the lower vertebra, and on the top of that is the exiting nerve root, which give us a safe triangle as a surgery approach for the minimally invasive procedures. So here we can see the difference that we have from Kambin approach and the subpendicular approach through the pedicles. That the blue ones that we have are the pedicles, and the exiting nerve roots and the nerve root of the lower level. So as we see here, I hope that you guys can see that very good. I think maybe maybe here because of the photos, it's not that perfect. Maybe now it's better, I think. So you can see this safe zone that we have. You can see this safe zone that we have between the existing nerve root and also the spinal cord, the green safe zone that we use for all of the minimal invasive operations, which is described through Dr. Kambin. So if we want to see that through MRI diagnostic, that's going to be the vision that we're going to see in coronal views of the MRI imaging. So the difference that we can see in OLLIF fusion operation and the transforaminal one and the risk of nerve injuries, we can see that here that these photos are took from Dr. Abbasi, that he introduced a very good the safe zone that we have through the Kambin triangle. If we take a quick look to the evolution of spinal fusion from the time that we got to know about the disc herniation, after that in 1944, the PLIF operations, and then from 1944 till 1980, that was the PLIF modification, till the time that in 1982 we had the transforaminal approach, and after that from 1990 to 2002, the colleagues, the senior colleagues, they started to use the minimal invasive spinal fusions till today, that we have the procedure of OLLIF. Yeah, we can take a look and in this image how it's going to be the different approaches that we use, and then now the OLLIF approach that based on all of the studies and the patients' outcomes, the thousands of patients that they operated through OLLIF techniques, OLLIF technique that we use. So the complications and the tissue damage that we get through that is much, much less than the other ones that it's supposed to be, because it's the minimal invasive ones. So here we have another time, from another point of view, the approach of OLLIF through the Kambin triangle. And if you see the other approach that we have also still now, and then we are using it, the OLLIF or lateral approach, that we have lots of risk of vascular injuries. So if you want to see the points and the surgery sites, here it gives us a gross point of view to see where we start our incisions for the different approach that you see. For the OLLIF one, we need the patient just in prone position, and we can do the ventral, the anterior and posterior procedures at the same time, and you don't need to change the position of the patients. So here you can see, for example, one of the difficulties that we have on the other lateral approach, that you need to go more anterior and you have more risk of damage of muscles, and especially the lumbosacral plexus. So if I want to summarize that the Trans-Kambin OLLIF, just per soft transition, we can emphasize 5 most important points. Single prone position, as I already talked about it, this is so efficient. So, and then we can do this procedure from 10th thoracic vertebra to the first sacral vertebra. That's a universal approach possible. And the real-time AP and lateral view that we have at the same time are X-rays, and we can see at the same time. So minimally disruption to posterior and anterior tissue with minimal blood loss. No muscle retraction, minimal blood loss, no disruption to muscles, anti-regression regulation. So you have a fastest ambulation and recovery and the very quick discharge, as Dr. Abbasi told us. Here we can see the difference between OLLIF and DLIF approach. As we all surgeons, we know that to reach the Kambin triangle is from the landmarks that we do in the surgery time and the damage that we can see as one of the complications in fusion operations. Here is very, very little one in comparison with the other lateral approach. Another thing that I wanted to say, all of the things that we say is based off many studies that I just collected, some of them here to just show all of the things that we say is study-based, and all of the from 2012 till now, there are dozens of studies that they can show us the benefits that we have from OLLIF procedure in comparison with other fusion operations. For sure, there are also some difficulties, but the good thing is that we have now the possibility to get the benefits and learn it very good from Dr. Abbasi as a pioneer and very avid spine surgeon with more than thousands cases.
Thank you very much.
Thank you for your attention. And here is my email. If you have any questions, it's my pleasure to answer them.
Thank you very much. So
you're welcome.
Without losing any time, we will go to our next speaker is Dr. Farnad Imani. He's the professor of anesthesiology and pain medicine at Iran University of Medical Science with 28 years of experience. And I would like to ask, with my curiosity, that what are the MIS procedures do pain physician, especially in Iran? Thank you very much.
Good morning, ladies and gentlemen. First of all, I have to thanks to you and my dear friends, Dr. Abbasi, to invite me to this webinar. About minimally invasive spinal technique that the pain physician perform in Iran is also including a epidural injection and for vertebral body augmentation, such as kyphoplasty, vertebroplasty, and also spinal cord stimulator implantation, intrathecal palm implantation, and about during these 10 years, some of the neurosurgeon, also pain physician, performed some technique of transfemoral endoscopy, and also epiduroscopy, and all central and peripheral nerve radio frequency neurologists. This is the most important technique that the pain physician perform here in Iran.
But we would love for you to go and give your presentation, Professor. I'm really eager to understand what is the status of spine surgery in the land where Dr. Kambin came from. He's a son of Iran. And if you remember, I was there about 6 years ago, or actually more, 8 years ago now. And I was trying to bring the technology back to my home country. Unfortunately, politics interfered with medical care. And I think we, as scientists, as physicians, we all must agree on that we should keep the medicine and politics separated and share freely the medical knowledge. So please go ahead with your presentation. We are eager to hear it.
Would you please show my slide?
Okay.
Angel?
Absolutely. Let me go to my... Tell me when you want me to advance it.
Okay. And for...
Could you make it full screen, please, Doc? Full screen. Full screen presentation mode, please. Try it again.
Tell me if you are able to see it.
Yeah, perfect, perfect.
Okay, please.
Okay. Thank you very much for I'm starting my talking. I'd like to talk about the spine. Which button I to press to go ahead? This is slide. Oh yes. I would like to talk about a little about the status of spine surgery in Iran. This is our university in the Iran, and
Please let me know. I can push the button for you, Professor. Whenever you are ready, say next, and I go to the next.
Okay. Thank you very much. Please next. Yes, this is one of the famous square in the Iran, in the Tehran Azadi Square. Next, please. For introduction, as you know, spine surgery varies significantly across the world, and each country exhibits unique approaches shaped by an array of the factors such as training programs, medical personnel, hospital infrastructure, technological advancement, and industrial influences. Next, please. And in Iran, these elements combine to create a distinct spine surgery landscape rich in its practices and challenges. We explore the current state of spine surgery in Iran, offering insight into its educational background, practical approaches, and technological capability. Next, please. In Iran, spine-related conditions are managed by a range of medical interventions are reserved for spine surgeons. Neurosurgery, demanding 5 years residency, offers extensive training in spine surgeries, focusing predominantly on degenerative spinal condition. Next, please. However, the curriculum often provides limited exposure to deformity surgeries, which are more comprehensively covered in dedicated spine surgery fellowship programs. And these fellowships, lasting about 1.5 years, are open. To both neurosurgery and orthopedics graduates, aiming to bridge gaps in residency training by focusing on areas like deformity correction for neurosurgeon and neural elements management for orthopedics. Next, please. After completing their studies, neurosurgeons are required to undergo a 3 years obligatory community service period. Their placement dedicated by the Minister of Health and Education range from teaching hospitals in the large cities to hospitals in smaller towns with only basic surgical facilities. This service period is pivotal in shaping their early surgical experience, particularly in spine surgeries, as they often work in environments with limited resources and high patient demands. Next, please. For service delivery in Iran, with a population close to about 9 million, has more than 1,500 neurosurgeons and about 100 spine surgery fellowship graduates. The spine surgeries are provided in 2 main settings, one in public and governmental hospitals and 2 in private hospitals. Next, please. The public hospitals includes both teaching and non-teaching hospitals, with teaching hospitals located primarily in the largest cities and offering the advantage of having attending surgeons, residents, and fellows. In contrast, non-teaching hospitals, especially in small cities, often have a single neurosurgeon managing the entire surgical load. Next, please. Private hospitals, predominantly in urban areas, provide an alternative but are absent in the smaller cities. Thus, public hospitals, especially in small cities, are critical in delivering spine surgery services, often staffing by newly graduated surgeons, fulfilling their obligatory county service. Next, please. The high incidence of road accidents in Iran result in numerous spinal injuries, necessitating efficient and accessible spine care. Public hospitals offer free treatment for road accident victims, including necessary spinal surgeries as part of a policy aimed at reducing post-accident disabilities and ensuring equitable care irrespective of patients' financial status. Next, please. As a result, young surgeons in these centers play a crucial role in the primary approaches to patients with traumatic spine injury. Within these trauma centers, surgeons employ various fusion and fixation techniques to address spinal trauma cases. Next, please. In thoracolumbar surgeries, the predominant fusion techniques involve the use of pedicle screws and rods inserted through open posterior approaches. Meanwhile, for cervical spinal surgeries, commonly employ fusion techniques include lateral massive screw, pedicular screw, and cages for anterior cervical discectomy and fusion, ACDF. Next, please. In lumbar spine is the most common site of surgical intervention. A condition like disc herniation, spinal stenosis, and instabilities being prevalent. Traditional open midline approaches dominate the surgical landscape, with some surgeons employing microdiscectomies using conventional retractor power. The adoption of minimally invasive spinal techniques such as tubular or endoscopic discectomy is rare, primarily due to the lack of specialized training and necessary instruments. Next, please. A variety of spinal instrumentation, including pedicular screw for cervical spine, lateral massive screw, transforaminal and posterior interbody cages, as well as expandable and mesh corpectomy cages and plates, is abundantly available. The utilization of the anterior and lateral interbody fusion techniques is infrequent, primarily due to gaps in formal training and the scarcity of specialized instruments. Next, please.
We are over 7 minutes, just for information.
Okay. While deformity surgery was once primarily performed by orthopedic spinal surgeons, over the past decade, neurospine surgeons have made significant advancement in this field. Next, please. MIS spinal techniques procedures are usually performed by spine surgeon and pain physician. This procedure usually performed around the CR, ultrasound, or endoscopy assisted system. In Iran, you have about 550 pain fellowship graduates. Next, please. The pain fellowship lasts about 1.5 years and is open to anesthesiologists by focus on areas such as percutaneous laser discompression, CS, intraarticular palm, kyphoplasty, injection, for epidural, epiduroscopy, and radiofrequency. Next, please. Neurosurgeons and pain physicians interested in pursuing advanced MIS techniques such as endoscopy procedure, for example, transforaminal interlaminar approaches, and IPD implantation, frequency fusion, often rely on self-directed learning through short courses or workshops. Next, please. The adoption of MIS surgery in Iran is lagging due to a lack of MIS in the formal spine surgery curriculum and the availability of specialized instruments, and the limited advanced MIS procedures performed by neurosurgeons in Iran are mainly confined to using tubular retractors or endoscopic assistance systems. Next, please. While spine endoscopic systems are available in Iran, their utilization remains limited to a small group of neurosurgeons and pain physicians. This restriction is primarily attributed to the lack of formal training opportunity and the high cost associated with acquiring these systems. Next, please. And this is my final slide. The landscape of spine surgery in Iran, characterized by its handling of high patient volume and a common spine condition, facing challenges and opportunity for advancement, and the integration of modern surgical techniques like MR surgery, endoscopic approaches, and robotic assist surgery is gradual, primarily due to gaps in training and limited access to advanced equipment. Thank you very much.
Thank you very
This
much.
is my final slide. Thank you.
Thank you. Thank you very much. So our next speaker is Dr. Choll Kim.
But
A Harvard graduate.
Apologize. Before we start that, I just want to make a final comment. And thank you very much, Professor. I was in Iran, and I have had lots of colleagues in different countries. And I can say for sure, there are lots of talented surgeons. And as a matter of fact, when I was in India last year and when I was in Iran, I noticed in our part of the world, which the West invest, it's called the third world, we don't lack skills. We have lots of skills. Certainly, we don't have the same resources as the West, Europe, and the Americas, but we have such talented surgeons. And what Professor Imani said, the lack of education is what is really missing there to bring that talent next step. And one of the advantage of Trans-Kambin approaches is that you don't need a $1 million or $5 million robot and the O-arm and so on and so forth. You need a set of tools that is available to everybody and lots of skills. And I'm hoping we will create that opportunity that Dr. Imani noted is missing with our society. So please, I'm very proud to have a good friend of mine, and I would say my teacher in a way, a mentor here to talk about two other things that I think are important. Number one is endoscopy, and number two, the fusion through Trans-Kambin approach. So I think without further ado, Dr. Anjum, please move to the next talks. Dr. Imani, if you don't mind, unshare your screen. So, and Dr. Anjum, please, the baton is passed to you.
Thank you very much. So our next speaker is Dr. Choll Kim, a Harvard graduate, is a double board certified minimal invasive spine surgeon. He's the founder of Minimal Invasive Spine Center of Excellence and former president and founder of Society of Minimally Invasive Spine Surgery. Most importantly, he is internationally recognized as an expert in the field of computer-assisted minimal invasive spine surgery and a world leader in laser endoscopic spine surgery. So, please, we are all waiting for your speech.
Thank you very much for having me. And thank you for all the great talks that I think are going to help me by providing the background. So I'd like to share my screen. How's that look?
Look great.
Great.
All right. So I'm supposed to talk about the history of the Trans-Kambin approach for endoscopic spine surgery, which turns out is one of my favorite topics. I'd like to just disclose that I'm a consultant for a number of device companies that specialize in minimally invasive surgery, including Eloquence. They make the endoscopic equipment that I use. So I think we've already heard why we're here in honor of a very important pioneer, Dr. Parviz Kambin, who I met personally in these. He, for somebody of his stature, is the sweetest, most humble, quiet person I've ever met. But he's truly impressive because he introduced us to this secret door, the secret passageway to the disc, where we can get there essentially in an unimpeded way. It's a small corridor, but that working triangle is the basis of a number of surgeries, including the entire field of transforaminal endoscopic surgery, and now the entire field of OLLIF, interbody reconstructive surgery, all through that little opening, which is both a blessing and a curse for all those that have gone through the learning curve of working in Kambin's triangle. But that is an important thing that's been contributed to the field of spine surgery. And what I'm talking about is a procedure that I called LESS, L-E-S-S, lumbar endoscopic spine surgery, which you have to admit is a pretty cool name for a minimally invasive procedure. But what is it? And in terms of the history, it has what seems like a very unique history, and that's what I want to focus on. Because it is the oldest state-of-the-art procedure that I have in my arsenal, in my toolbox. And it's been around for probably 40 years, culminating in 1999 with a landmark study by Parviz and his coworkers. That was in 1999. That means that the work went on in the 1990s. That is 25 years ago. And still we're talking about this like it's new and exciting and investigational in some ways. And since then, not only Parviz, but a number of really smart, dedicated, what I call OGs, original gangsters, Parviz, Tony Young, my mentor, and a number of other people, Sang-Ho Lee, they're all here, but they're the originals. They're like the Yoda or like the Dark Sith Lord. They did a lot of work. And then a second wave of really dedicated surgeons came on. They're like the Anakin Skywalkers and the Obi-Wan Kenobis were the second wave. And we as a collective, we did a lot of things too. We all together did studies, improved the equipment, give talks, did lots of cadaver labs, etc. A lot of work has been done. And in fact, if you go to PubMed and you type in endoscopic spine surgery, the number of peer-reviewed published articles is staggering. If you can guess, it is in the order of thousands, like it's probably 6,000 now. If you compare that to XLIF, MIC-LIF, and microdiscectomy, combined, it's not even close. And when you start having that many studies, a couple of things happen. One, people start doing lots of systematic reviews and meta-analyses, starting with one in 2010. There's been multiple since then. And in 2018, they did a meta-analysis and a systematic review. And that's not the only one. So it's clear there's tons of data. And the first question, does a transforaminal, Trans-Kambin endoscopic spine surgery work? Because that's the first question that people ask, even to this day. And the answer is absolutely, positively yes. It's not perfect. It's like all procedures that has a benefit and the risk. It has people that are good at it and people that are bad at it, but all the studies say the same thing. It is highly effective, and it's as good, if not better, than microdiscectomy surgery, which that is probably the best surgery that we do. It's probably the best, one of the best surgeries, period, on the planet. Probably the only thing better is a total hip replacement and maybe a coronary angioplasty, but it is competing with the best surgery that we do, and it's still just as good. So the history that's interesting to me about endoscopic surgery is it's been around for so long, and we all think that it's so great because there's the group of people that do this. We are like evangelists. We're not like, oh, it's okay. You start talking about endoscopic spine surgery, and all of a sudden, people like me wake up, and we're excited about it. So what I think is interesting about the history of endoscopic spine surgery is that if it's so great, how come everyone is not doing it right now? And I think we kind of already know. There's two main reasons in the US. The first is reimbursement. That's a topic that I'm not that great at, and it triggers me. And the second thing, which I think is even a bigger deal, is the learning curve. Turns out the learning curve for endoscopic transforaminal surgery is very, very, very difficult. Way more difficult than other surgeries. So, I've been trying to teach people how to do MIST-LIF, XLIF or lateral surgery, percutaneous pedicle screws with navigation and endoscopic surgery. And it is absolutely clear to me, the hardest thing to learn is endoscopic surgery for a variety of reasons. And in a review of, the learning curve, it ranges from 35 to 72 cases. That is way too many to drive adoption. It has to be a few. And eventually it will be taught in a fellowship program, but almost all new surgical technologies don't get adopted through fellowship training. It gets adopted through the community surgeons learning from other community surgeons that are pioneers in small courses, adopting it. And once it becomes almost the standard of care in the community, then the training programs start adopting it. Then they start doing the randomized controlled trials after it's already too late. So a learning curve that's anything greater than probably 5 is too much. So we have to ask, why is the learning curve so difficult? Because of those 5,000 publications, very few are about the learning curve. And almost all of them are just simply, the learning curve is difficult. Thank you very much. You have to dive deeper, because by asking the question why, that's the only way we can address the next question, which is, how can it be improved? And in the interest of time, that is an entirely separate talk. But in terms of the history of endoscopic surgery, that is the thing that I found the most interesting, because I don't know of another procedure that is so promising, so awesome, procedure that I would do on myself or my family member if they needed this surgery. Why is it taking so long, and what can we do to fix it? So the learning curve is what we should be thinking about in terms of the history of endoscopic surgery moving forward through a Trans-Kambin approach, because we should use this opportunity to figure out how other new technologies are going to be adopted easily and quickly, because this is an example of how not to do it. So I know how not to do the endoscopic learning curve. I just have to learn how to figure out what to do. And that's going to probably be a lot more education, things like the society. And things have changed, because I could never do a conference like this and give a talk like this in the middle of my vacation up in the mountains with very little internet access, but thank God I have good Wi-Fi. And at the same time, we're just building better equipment, just like golf. Every year, there's a new driver. My brother gets a new driver, and he's now out driving me. And instrumentation helps. And then, just like in Iran and many other places, including the US, you got to practice. It's like any sport. You got to practice, practice, practice. And we need to figure out ways to do that. And then finally, we need to expand our mentorship program. And the days of the internet and Wi-Fi and high-speed access, where we can instantaneously communicate with people across the globe like this in real time through video conferencing, is tremendous. And we need to do a lot more of this. And that's why Hamid Abbasi is so great, because he's already doing all of these things. So we have a lot more work to do, but it's good work. It's work not to figure out what's working well, but to figure out how to get more people to do it well. So with that, thank you very, very much for having me.
Thank you very much.
I have a final comment on that, and Choll, I'm really proud having you on board here. As words of Isaac Newton, anything I did is on shoulder of giants. Choll, you are one of those giants, and the next giant in this series is our next presenter, who MacGyvered with his knowledge, with his vast anatomical understanding, how we can use that little space for more than just endoscopy. I did meet Dr. Kambin. Unfortunately, he passed away, but 9 months before he passed away, we had a conversation. And when I showed him what we are doing with the fusion, he was so amazed. Not even he thought that this small anatomical path can be used for fusion. Yet we have now Dr. Gerald Schell, one of the pioneers, one of those giants that all my knowledge is based on, to give us a perspective on the history of what the steps were, how did we get there. So without further ado, I'm really honored to have Dr. Schell on board today. Please, Dr. Schell, go ahead.
Can you see me okay?
Yes, we do.
Okay. Well, I've been at this for a while and kind of used about every possible strategy to help these poor people with this back pain. This back pain is just awful for people. It devastates their lives, their families, and the surgical techniques that were being used were good, but not good enough. And so it's been a constant search for trying to develop a procedure that could adequately address the issues. I came upon the Cayman's Triangle through the endoscopic things, which Tony Young introduced me to. Tony Young was very adamant that he would never do a fusion, that he could do everything through endoscopic. He certainly could do a lot through endoscopic, but eventually I convinced him to do a spinal fusion through Cayman's Triangle, and I think he, at the end, joined up with us in that endeavor. But the first one was done actually back in 2010. So I've been working through Cayman's Triangle now for about 14, 15 years. And right now it's the mainstay of my practice. About 80% of the spine work that I do is outpatient, and we take all comers. There's very little circumstance in which Cayman Triangle can't be used if a person is attempting to do an interbody fusion. It can be done very safely. I think it's been kind of shut out, and it's still kind of like a new thing, because I think there's a lot of pressures from the big companies and a lot of the money people in the industry that are looking for profit margins, and the work through Cayman's Triangle can be done pretty cheaply, inexpensively, and really hasn't taken hold because of that. But the first case was done when I had a patient who had what was called an Optimesh bag back in 2010, which was the so-called bag of bones. It was a mesh bag that was placed through Cayman's Triangle. And the patient came to me just incapacitated with pain. Apparently there was a reaction of the Optimesh bag to the end plate, and maybe a little bit of stress in the neuroforamen, and had been to several surgeons who recommended an OLLIF or translaminar decompression to revise that. And I looked at the back and thought, there was a pretty wide open inner space, and it looked to me like a little bit of a slip. So I thought there was more room in the Cayman's Triangle. So I thought we could attempt to take the bag out just through the approach they used to put it in. So simply made an incision, and within 5 minutes, the whole bag came out with the pituitary rongeur, which was really quite amazing, because there's quite a bit of pathway there. And it just was fortuitous that the case before that, I had worked with a startup company who was showing me a new tapered bull shark cage, pliff cage, that I'd used in the case before. So I thought, well, why can't we just put, with this bag came out, let's put some bone, decorticate a little bit more, and put the peak interbody cage in. So I did that and did it through Cayman's Triangle. The patient was amazing. Instantly, the pain was completely gone and remained that way. So the outcome was phenomenal. It was a 15-minute procedure. And the engineer, who was also at that point also showing me the bull shark cage from the startup company, we've looked at it and thought that it should be developed. So Ken Barra actually is working now with Dr. Abbasi, and he was the engineer who then was at that case and helped me develop the tools and instrumentation for that. And I've personally gone on, we've done a couple thousand interbody cases through Cayman's Triangle in the last 15 years. And we've taught docs all over the country. And Ken, are you available to come on and show some of the progress after that first case and how that developed from then?
Yeah, I'm here.
Did you want to get on and explain that to us?
I don't really have any slides to present, but yeah, we can talk a little bit about the development of the system.
Yeah, I think just go over what happened after the first case, where quickly how you developed the products, what they were. I mean, they're pretty simple products. I mean, we developed simply did we were big on stimulation to try to stay away from the nerve root and make sure the pathway, the orientation approach was such that it didn't tilt down near the nerve root, but what came from under and through the widest part of Cayman's Triangle, and developed the tools to do that. And Ken was very instrumental in doing that for us. and went back and patented it, and had a number of players from that company work with him. And just if you want to say a few words about that, Ken, go ahead, because I think I'm pretty much done.
Certainly, following Dr. Choll Kim's reference, Dr. Schell is the OG of the Trans-Kambin interbody fusion here. I was very fortunate to work with him and several other very talented surgeons that were on the cutting edge of doing minimally invasive surgery. Notably, I'm surprised Dr. Kim didn't mention Dr. Osman. Dr. Saeed Osman did a lot of work with endoscopes for Trans-Kambin. And then Dr. Randy Bishop and Dr. Will Talley, who I know Dr. Abbasi went to visit during his initial exposure to the Trans-Kambin OLLIF. So worked with a lot of those guys.
You're killing me right now. I knew I was going to forget a bunch of people. You're so right. In my own defense, you're totally right.
Well, Saeed Osman is just he's a wonderful guy and a wealth of knowledge and always pushing the boundaries.
Absolutely.
Going back to the development of OLLIF here with Dr. Schell, we've been working on a transfacet screw with Dr. Schell, and that was the reason I was in the OR and spent time with him. And we developed some of those instruments. We took that initial dilator and access portal and started developing discectomy instruments through that and expanded on it. Took inspiration from a lot of things that were used in other ways, found interesting new ways to put big instruments through a small cannula, like especially the flexible curette blade is a nitinol blade that deforms going through an 8mm cannula and reshapes itself into a 16mm curette, which that kind of empowers these kind of procedures, putting expandable devices through small access portals, and then being able to do a very thorough and robust discectomy. And those were all things that I took a lot of inspiration from surgeons like Dr. Schell, Dr. Talley. We worked with Dr. Sahai in Boca Raton. Another endoscopic OG is Dr. Jeff Katzel, who we spent a lot of time working with. And just took all those, developed a couple of implants that started the whole OLLIF process. Had a lot of surgeons coming and visiting and collaborating and working. And it was just a wonderful collaborative experience with training, surgeons coming to OLLIF cadaver trainings, bringing their experience from other endoscopic procedures, international surgeons. We had a lot of interest from surgeons in Colombia and Mexico and Brazil, and incorporated a lot of wonderful input from all of their different things, going back to the topic of surgeons like in Iran that have great skills but don't have all the same technology available. That was something that we saw. Dr. Schell went with us to Mexico to do some training labs there, and the surgeons were all very capable and ready, but they didn't have the access to that technology. And that was one of the great things that we were able to do with OLLIF, is compact all of this into a very small instrument set that's very concise. It doesn't require lots of extra external pieces to do the surgery. And that was one of the key driving factors from all the surgeons we worked with, was to keep it simple, not make it all complicated, find the least number of instruments, combine the steps so that we're not adding complexity, so that we're keeping it as simple and maintain that minimally invasive approach. And that led from the origins there to working with Dr. Abbasi and advancing that through the last 6 years at Advanced Research Medical, Inspired Spine, and all the great work that he's been doing to evangelize the OLLIF approach.
Well, thanks, Ken. I just want to finish by saying that it takes a real organized team to really build on this, and I think this is a new chapter for this procedure. I think the Kambin approach is really the key, and it's good people that are here today that hopefully can bring the team back and start promoting this, because it's something that is not costly, can be done outpatient, much safer than the much larger procedures. And old guys like me can do maybe not as many cases as Dr. Abbasi, but we're still pretty active and able to keep going. So I think it's a wonderful procedure. And thank you for having me. I appreciate being part of this.
Thank you, sir. Thank you very much for your speech. So I would like to invite our next speaker, Dr. Varun Agarwal, is one of the best neurosurgeon and spine surgeon in Bareilly, Uttar Pradesh, serving robotic and endoscopic spine surgery. And today I request him to speak about the expansion of OLLIF in the Indian subcontinent.
So, am I audible?
Yes, sir, you are audible. Yes, sir.
Thank you, Farah, for such a great introduction. I would like to just make a small correction. I'm an orthopedic surgeon, by the way. So I'm the odd one out here. And the Trans-Kambin approach is quite popular in our part of the world. And now it is being extended to all these fusion surgeries. And OLLIF is the new in thing now in our part of the world, basically because it is much faster, safer, and much more predictable for the patient. And I'll be sharing my presentation, and you would all be surprised to know that in my hands and in our part of the world, we are doing surgeries like OLLIF under local anesthesia and conscious sedation. And because ours, like Dr. Abbasi said, are resource restricted countries, we don't have things like neuromonitoring. Patients are very reluctant to go to ICU, and we have patients with all age factors and cost factors. So this is a surgery which is particularly useful, and I'll be sharing some of the tips and tricks and showing how we go about this. So I'll be sharing my screen now.
Perfect.
Short presentation for the tips and tricks and how we go about this under local anesthesia. These are the routine cases which we kind of see daily in our practice, single level listhesis, and everybody is out for their lives, and these are all surgical candidates. I think everybody and every one of us are sure about this. Most of these patients, some of them do quite well for while on conservative. Some require surgery, but those in between who are not responding to conservative and who are, not fit for surgery, for general anesthesia, maybe, high risk group of patients with cardiac diseases and chest diseases, etc. So can we help those kind of patients as well? So, or are these patients without any hope? So this is how we do it in our setup. The preparation for the patient starts in the pre-operative room itself, so that we have low amount of time the patient spends in the OR, because we find that a conscious and a awake patient starts to get panicky in an OR environment. So we try to do all the pre-medications well in the pre-operative room, and this also makes the surgery quite efficient and cuts down on the OR time. So the pre-op medication 5 to 10 minutes before shifting the patient to the OR. Now we have the painkillers and the regular pantoprazole, tramadol, etc. Catheterize the patient in the pre-op itself. The ECG stickers, cautery pads, the IV cannulas, epidural tube, if it is all needed. It can even be placed one day prior, so that least amount of OT wastage time is there. Sensitivity testing, vital charting, everything else is done in the pre-op itself. So patient is made prone, and I like to do this procedure under prone. There are some centers who are doing under lateral, but I'm really uncomfortable doing that. And we check compression over the eyes. The patient is made very comfortable. Neck position is checked. Patient is asked repeatedly that whether he is lying in a comfortable position or not, because you find that the surgery in itself is so painless that a patient doesn't feel anything, more or less. But if he's uncomfortably positioned, they start to fidget, and then it starts creating a problem in the OR. So forearm is placed over arm support, upper limbs are secured, axilla is padded, bolster is at the chest level. All these are regular things, but the patient is cushioned and made very comfortable on the OR table. And so as you can see, the patient is secured with the strap. So the patient is secured with the straps, etc., so that he doesn't move a lot, and he has a very restricted sphere of movement during the surgery. And it is not that he's very tightly tied down to the surgical table and make him uncomfortable for that. So you can see here, this is the tape which I apply over the epidural line sometimes when it is needed, so that I can, paint and drape over this as well. And I secure the arms, etc. Again, lightly tied so that the patient doesn't make, sudden movements. And I like to keep the lower limbs free so that I can see that the movement of the limbs is there, because we are not using neuromonitoring in our setup as the patient is awake. And you see how the abdomen is completely free. This is a Jackson table which I use so that there's no pressure over the abdomen and the patient is quite comfortable. And sometimes in these obese patients, you see even the Siam picture is not that clear. So for that, we have this trick where we use the tapes, etc., to just mobilize the fatty part of the body away from the surgical level of interest, so that the Siam picture then tends to improve. So this is how you see, just lifting up the abdomen and securing it with tapes, and you see at the end, the picture is much improved, and you can, well identify the landmarks for the surgery. So again, patient electric warmer I use so that the patient is comfortable again. The Siam, we sometimes use single Siam, and now after Dr. Abbasi's visit, we have now started using double Siam, and I tend to write all these angles on the Siam with the tape so that my X-ray technician doesn't forget and doesn't have to, fiddle with the X-rays too much. He just reaches the position, again, mark the Siam position on the floor as well. And this is how it looks like with a dual Siam setup. And this is the anesthesia protocol which we use. We use just a local infiltration of 5 ml of lignocaine with adrenaline, 10 ml of sensoricaine and NS. Dexmedetomidine infusion is used for sedation and also for lowering the blood pressure of the patient. We use IV fentanyl bolus dose at really painful parts of the surgery, and a little bit of Medas as an anxiolytic dose rather than a sedation dose. And if needed, especially during the part of screw placement, we can do an epidural short-acting sensory epidural as well. And these are the instrument sets which we use, and routine targeting of the level. All this is well aware. So this is another case the which I showed, endofusion, pain in the back, radiation to lower limb with the SLR 20 degrees, MRI showing listhesis, and you can see the stenosis there. And this is the dual Siam position, and you can see here that this is the short surgical video I made, and it is also available on my YouTube channel. And you can see that the patient is well awake, and she's quite comfortable. When we are doing the surgery, the patient is awake, and they tolerate it quite well. The last patient I did, the movement of the patient was so much that I couldn't see anything under the Siam. And then I realized that the patient was so comfortable and asleep that she started snoring on the table. And then I had to time my Siam shots with the, end of expiration and inspiration so that I can get an image. You can well imagine how comfortable the patient gets. And now again, local anesthesia, again for the screws. You can see the patient is well awake. The standard technique of the Jamshedi needle, the guide wires. And this surgery under local anesthesia truly makes this an outpatient procedure. The patient is sent home by evening or morning next day. So I should, I'm just skipping the video in the interest of time because this is just regularly the screw placement. And you can see the guide wires, the taps, everything is being done under local anesthesia. And even the rods passage, everything under local anesthesia. And then at the end, the reduction towers are removed. So this is how the final construct looks like in the AP view. And these are the transverse screw incisions because I find these are more cosmetic. So I've started giving transverse incisions, the rod insertion incisions. And for the cage and even the bone graft, we just harvest it under local anesthesia with the help of power trifines and drills. And this is the immediate post-op. And by evening, we mobilize the patient as tolerated by the patient. You can see she is very, very comfortable. So this is the question we always get. Can we do adequate disc preparation? And I hope this is this picture shows that an adequate disc preparation has been done. And will it crush the exiting room? So you can see in this video, this is the cage, and how as it goes, it just slides under the exiting nerve root and just pushes it out of the way. And since the patient is awake, we are sure of what we are doing and we are not doing any neurological damage. So this is another question. So will it fuse? This is a 55-year-old male with the listhesis at L5S1. You can see the listhesis there. This is the MRI. And again, the fusion which we did. And after 2 years, this is the CT scan. You can see it has fused beautifully well inside the cage as well and outside of the cage as well. So a lot of graft is being packed outside the cage also. So another, is it just good enough for one level? So this is a case, L3, L4 listhesis and reduced disc height L4, L5. Did a 2-level, again under local anesthesia. Another case, listhesis and reduced disc height, 3-level fusion. You can see on the dynamic X-rays, the amount of instability and the MRI showing the compressions. And this is the construct, again done under local anesthesia. And this is the post-operative MRI, and you can see that the indirect decompression, immediate post-op, is quite well. You can see here, all the levels are quite well decompressed by the indirect decompression there. So another case, this was a case in which he had a adjacent segment disease, and he was fused at this level by an open surgery. So we had an option of going in again, opening it up, and then again fusing it. But the patient was not very suitable for general anesthesia, and we decided to do again the OLLIF, and this is a strategy we took. We just did one level above and bypassed the entire construct so that we didn't have to open. And this is the post-operative picture. You can see this is the scar of the previous surgery and the scars which we had given this patient. You can see the big difference there. And again, this patient was a cardiac case and had some chest problems, and he was absolutely not fit for any general anesthesia. So the take-home message that Trans-Kambin fusion is safe, effective, and very efficient. So the fastest which I have done is under 28 minutes, skin to skin. And we do it under local anesthesia. It is now a very efficient technique in our hands. Careful patient selection and thorough knowledge about the procedure is mandatory. And if indirect decompression can work from the front, it can surely work from the back as well, like I have showed in the cases. And we always have the option to use an endoscope or a tube or whatever if you want for a direct decompression as per the demand of the case, which we can do it in the same sitting if we are doing it under general anesthesia, or maybe do it in a second stage as per the circumstances that allow. So thanks a lot.
Thank you very much. It was a great elaborated talk. Thank you very much for sharing.
So much, and I would like to thank Dr. Abbasi for coming all the way to India last year and pushing the procedure.
I would like to add just my say my greatest thanks to my Indian colleagues. For me, it was an eye-opener to be in India and see so much talent in one place. And where invest, we rely on $5 million instrument and so on. With so little, they do so much. And everything like in the United States, we are so proud of ourselves doing this and that. Our Indian colleague has been doing it for 20 years. And I have never seen that many talented and skilled people in one place. So that was for me an eye-opener that the world is becoming multi-central, and India definitely is one of those centers. And I'm so proud to be getting the help of our Indian colleagues to know, as we talked about. I'm so proud as we talked about that. So please.
Thank you, Dr. Abbas. Very kind. You're very, very kind for your words of appreciation. Kind. for a word of appreciation.
Dr. Anjum,
Yes.
our next presenter is a celebrity. Why don't you go and introduce Dr. Crunch?
Yes, she is also like one of the example to be a lady spine doc. That's how she is famous in Instagram, and she is having more than 23K followers. And not only she is a board certified neurosurgeon, and she is board certified neurosurgeon. And do I have? She's doing minimal.
Can you hear me?
Yes, yes. I'm just so excited. I'm talking about you still now that you are a mother and you are a neurosurgeon and you are top doctor for several years in Georgia Train Atlanta magazine. And you are also specialized in minimal invasive spinal surgery and honored as a woman, marking a mark in 2023.
Thank you. Can you guys hear me and see my slides? Okay,
Yes.
okay, great. All right. I'm embarrassed. Thank you for the introduction. And thanks to Dr. Abbasi. I actually I'm at a conference in a spine conference in Las Vegas and I had an unexpected change in the schedule. So I appreciate you guys letting me jump on and give my quick talk here. And I am just honored to talk to all you guys across the world, excuse me, on Trans-Kambin surgery. And I've been doing Trans-Kambin surgery since 2016. And I'm just going to quickly talk about my experience in this approach for revision surgery, which I think is truly where this approach shines in spine surgery, and how I think how applicable it is to revision surgery. And yeah, let's see if I can get this going here. There we go. So like I said, I've done over 600 Trans-Kambin fusions since 2016. I do about 10 a month. I've taught 75 surgeons in the US this approach. And of course, we all know kind of the trajectory and how we do Trans-Kambin surgery. And if you know me, you know that I like to make videos. So this is a little video on Trans-Kambin. We make it look cool. So actually you can do a fusion in just 20 seconds. No, just kidding. So basically, you know, when we're talking about Trans-Kambin surgery, obviously we all know the benefits, and all of you guys have been celebrate this amazing approach and why it shines over other approaches. But the thing that I think that is awesome about the approach is it's so easy for revision surgery. And you know, this is just a case example of how it can perform in a primary surgery. This is a patient with a spondylolisthesis at L4-5, a little bit of foraminal stenosis. She came in with right leg pain because she has this asymmetric collapse of her right L4-5 disc. She failed conservative treatment. She had a mobile spondy there. And you can even see on this AP and the lateral x-ray intraoperatively before I even did the fusion how well that asymmetry was corrected by just the Trans-Kambin approach and implant. And, you know, I did percutaneous screws, did the decompression, and then this is a anterior posterior surgery in an hour and a half with 5 cc's of blood loss, and she can go home the same day. So just a truly, truly amazing approach. But we know it's great in those cases, but what about the hard cases? So, you know, you have cases like this that come in, or at least I do. This is a patient, like a 72-year-old guy, came into me for severe debilitating left leg pain. He's had 5 back surgeries. This is his x-ray. This is actually scalp from the CT, but this is what his x-ray looked like. He had a revision surgery at 2-3 to help him with his pain. His pain got tremendously worse after this procedure. He was in a wheelchair. And on his imaging, this is what we see. He had this kind of abandoned 4-5 fusion, 3-4 fusion, and then this is his new fusion at L2 and L3. And you can see osteolysis around the end plate here of the 2-3 interbody spacer, and then his sagittal CT, the screws haloing significantly around the screws, and you can even see that on the coronal here, or the hailing around that left L2 screw. The screw is medial, in my opinion, too, and I think is one of the reasons why he was having this intractable pain. And so, you know, you can see on the coronal view where the implant is off to the side, there's no bony fusion mass at all. And the other thing is that there was the facets were taken down for the decompression. So these are challenging cases. So, you know, I did a Trans-Kambin approach on the opposite side. You just take a steeper trajectory to that disc base, come lateral, you know, through the Kambins and drop an implant, you know, right beside it. And this is, you know, takes 20 minutes to do that procedure. This is the approach that I use. This is a different patient, but you can see where we just took a slightly steeper approach, did the right as the intraoperative balloon placement of where we would put the implant, in the left image there as the implant after it's placed. This is his final x-ray. I also revised and replaced the screws, put a bone stimulator in there, bone growth stimulator, because of a pseudo. And his surgery is in 2019. We did the entire revision. I do Trans-Kambin open and minimally invasive. I do the implant perk through Kambins, and then I did the revision fusion open. And this is his x-rays. And immediately after he woke up from the surgery, just complete relief of his pain. And it's done great. I actually went back in. He had a spinal stimulator done before he came and saw me, and I was able to remove that because he didn't need it anymore. Here's an even more complex case. This is a 65-year-old lady who came to me. She had had multiple surgeries. She has had 5 revision surgeries for this construct alone. She kept having failure and a rod breakage at the thoracolumbar junction, severe persistent thoracic pain, and no surgeon. She went and saw another surgeon, and no one would really help her with her pain. The primary surgeon had done the rod breakage, had actually passed away, and so she came to see me to see what we could do. And her hardware was intact, and, you know, clinically speaking, there was nothing wrong with her hardware, or anything to revise per se. We did a CT scan, and here you can see, if you take a real close look, you can see at several levels that I have starred that there's gaseous changes within the disc space. So clear motion there, and that's where her rod breakage was. So, you know, what would you do in this case? You could punt it, tell her there's nothing that you could do. You could run, and that doesn't really help her at all, but it helps you. So for me, what I did is I talked to her about doing a Trans-Kambin approach. So I navigated 3 implants into those spaces. Of course, this is off-label, but 60 minutes, 1 hour of surgical time, 0 blood loss. She went home the same day. I did a chest x-ray in the PACU to make sure no pneumothorax. Here is her imaging 3 years later. On the right side, you can see all no more gases changes within the disc space. She had complete resolution of the pain in 1 hour after surgeons had done so many different revisions for her. And here's another case example, 62-year-old guy, L4-5 fusion in 2021. He had 1 year post-op, he had pain, and then 6 months progressive pain. I don't have all the imaging on here, but you can see it has a synovial cyst adjacent to his 4-5 pain. And he actually had a pseudoarthrosis at 4-5. So he had a pseudo at 4-5, adjacent segment disease at 3-4 with a large symptomatic synovial cyst. And you can just kind of see the MRI there. And so what I did in his case was in a single approach is dropped a Trans-Kambin fusion implant at 3-4, which is the synovial cyst level, and then augmented his 4-5 pseudoarthrosis with the implant right beside the old TLIF. And here is an intraoperative CT. You can see we're just placing that right beside the implant at 4-5, and he did great. Here's another example. On the right, you can see the coronal images of a failed pseudo at 4-5, and there's a peak implant at 2-3. And they did a posterior lateral fusion at 3-4. He had a multi-level pseudo, and this is his post-op CT at 18 months post-op. So just robust fusion in this patient. And the remaining time I'll have just a couple of x-rays showing, you know, how we approach this. Again, it's just a slightly steeper approach. There's another x-ray, more pictures of a pseudo. In the US, we have a lot of surgeons that do, I don't do unilateral pedicle screws, but it seems to be a popular trend. And those patients, in my opinion, just don't have the biomechanical support for fusion, and they tend to break down in these TLIFs. There's a picture of the implant right beside the old TLIF cage. So yeah, thank you, Dr. Abbasi, for having me here today. Thank you for letting me kind of jump on here at the last minute and interrupting y'all's conference so I can get this talk in.
Well, thank you so much, Betsy. This is always a pleasure having you on board. And you have mentioned few things that I need to reemphasize. You take care of patient that nobody else wants to take care of. And not because the other surgeons are bad surgeon and so on and so forth, but because you have a tool that reduces the risk associated with surgery. And in the balance between risk versus benefit, you just, with your technology, with your skills, you can help a lot of patients. Now, my question to you is, what percentage of your patients are patients that other surgeons have rejected? And what percentage of your patients are actually revision? Now, you get, I'm sure like me, you get a lot of patients that they didn't have a previous surgery, but they are elderly, they have comorbidities, that other surgeons agree something needs to be done, but they say it's just not safe to do the surgery. Unfortunately, sometimes when the surgeons say it is not safe to do the surgery, they mean it's not safe for my practice to do the surgery. Meaning,
Right.
because we know for the patient, if they are in pain, they're suicidal. They don't want to live. If they start, if they stop ambulating, their life expectancy goes down. So, but your practice, number one, what percentage is the revision? What percentage is the reject of other surgeons?
I think about 50% of my practice is revision. It's a big component of my practice. And I wish more surgeons did exactly what you said. You have a problem, but I can't fix it. I think you need to go see X surgeon. What I tend to see, and I really just hate this approach, is, a surgeon may just tell the patient there's nothing that can be done. And then they accept that as what the opinion may be, and they may not go seek another opinion. So or they tell them that it looks good when it clearly doesn't, acknowledge the pseudo, or they want to shield themselves from being subjected to having to revise it, or the patient expecting them to revise it. So I wish more surgeons were honest with themselves and told the patient, hey, you have a problem. I think you need a revision. I'm not skilled enough to handle it. I want you to go see this surgeon. But I just don't think a lot of us are honest with ourselves as surgeons to do that. But the patients that I see are ones that, maybe decide that they want to go have another opinion. And I think I think that's why it's important to really encourage patients to get a second opinion, because there are surgeons, not saying that we're better than the surgeons that do any other approach. It's just a skill set that is really, really great for certain problems. And in these TLIF revision surgeries, this approach is phenomenal. So yeah.
So we are all in debt to you to spreading the knowledge, and everybody in our group is a fan of yours, and I myself closely follow you, and I admire you, how you are willing to put yourself out there.
Well, thank you.
Have made the impact of bringing the knowledge to the populace, to the public, and I think that is way above and beyond that any surgeon can go. So I'm really proud and honored to have you here, Betsy, and thank you for jumping in on your busy schedule, and thank you very much for doing what you do.
Thank you. Y'all have a great day.
So we can safely say that
Thank
the
you very
grandson
much.
told.
And you are kind of my mentor, because you are like work-life balance of being mother, wife, and ladies fine doc. So
Thank you.
lots of love.
Thank you, guys.
So now we will go to our next legendary. Why he is legendary? Because he's one of the few neurosurgery board certified, both in US and in Europe. He is Jaime Gasco. He's 23 years experience and is specialized in brain, spine, and peripheral nerve surgery. And today I would like to request him to talk about experience with L5S1 grade 2 spondylolisthesis, please.
Can you guys see the screen okay?
Yeah, perfect.
Yes, sir.
Okay, so thank you so much, Hamid, for this opportunity to talk to you and the rest of the group. You've been my mentor. You taught me this technique mid of 2021. Choll also has taught me some of his endoscopy skills. So I'm very grateful to you both because you've expanded my career and have really helped me, produce changes clinically in the patients that we encounter on a daily basis. So I work out of Texas in El Paso, and I'm a clinical assistant professor at Texas Tech University and part of the Nexus Neuroscience Neurosurgery Group. Today, I'm going to talk about OLLIF in the context of high-grade spondylolisthesis, which is a very nuanced procedure. What are the relevant points to consider? Well, one is L5S1, as you all know, the crest position is going to be very important. Whether the facets are open or fused is also going to be relevant. The root position, I always try to look at it in the MRI with regards to the Kambin's triangle. Always take into consideration the pedicle anatomy because, in my opinion, when there's a severe spondylolisthesis at L5S1, what happens is the pedicle is dysmorphic. It becomes more elongated in the anterior-posterior axis, but it also becomes thinner in the craniocaudal axis. So it's a smaller pedicle screw, and your precision in placing the screw is absolutely key. The disc height obviously is relevant in those cases where the disc is collapsed. It may be easier to do your disc prep because it takes less time. Always look at that consideration. Take a look at the L4-5 level and take a look at the level below. Make sure that if there is a Bartoloti variation, you consider that in your construct. And also, I would recommend everybody to obtain a bone density study on everybody that's over 60 years old and anyone who's a smoker, regardless of the age. As it was shown previously by one of our colleagues, the taping technique that I'm doing now for very obese BMI 45 or greater, this was a BMI of 51. We tape over the top to the contralateral shoulder from the belly up, and also to do the same thing caudally and then across. So we find that this helps a lot with the X-ray technique. Everybody has a very similar operating room setup, and it has to be consistent. It has to be always the same, and I encourage everyone to use the same intraoperative team every single time. We're going to go to case one. This is a lady in her 40s, early 40s, who presented to us in 2023 with this image in the bottom right. And as you can see, in 2014, things didn't look that bad. What's interesting to me is how she progressed in 5 years from point B to point C. And also from point C to point D, you can see that level of compression in the nerve and the amount of pain that she was very significant. In flexion extension, she moved what I would consider to a grade 3 with what looked like almost auto-fused in that segment, but there's a little rim of bone gap that you can see there. So the footprint is very, very challenging. And so I told her before the surgery that we may not be able to do it. It was my first grade 3 spondylolisthesis after maybe about 125 cases. So I kind of jumped into the fire and gave it a go. One consideration that I want everyone to take a look at this is the proximal port. Consider that the proximal port in the skin and then the distal port. The wire has some leeway, right? Has some leeway between the proximal and the distal port. So you can actually change the angle because you have the tricalcium phosphate waiting for you. And you can anchor that wire in a specific angle that's going to condition the way that the cage is positioned at the end. So my thought process with this case was that the wire placement was going to be key. So if you see in point 1, this is the first thing we obtain the pedicle, blood for bone marrow. And then the next step that I did was to place that wire into the disc space. Once we obtained that correct trajectory, the rest was the standard procedure. And I knew that I was not going to get a complete reduction. I didn't want to do a facetectomy and bring her back and obtain a complete correction. I just wanted to get her to a better place. And what's interesting with her is that she actually obtained a pretty good reduction, as you can see here, but also fused very well after 6 months. Her clinical symptoms completely resolved, and I was very happy about those things. Take a look at this picture here, how the screw is exactly and precisely within the pedicle boundaries. It's very, very important. And I think, nowadays people relying on robots and things, the X-ray does not lie, but the robot and navigation systems, they can create a 1 millimeter difference, and that is enough to bring your success to failure. Case number 2, another grade, I would consider this a grade 2 with vacuum disc phenomenon, listhesis of about 14, 15 millimeters. And we reduced it to just probably about 5 millimeters in this red line, because this is not measurable, because it's not calibrated, but we obtained a pretty good reduction compared to how things look, and a good distraction and a good cage placement. This was, I think, a 12 millimeter cage. Case number 3, very similar again with, this disc anteriorly with this listhesis, with a little bit of a disc fissure at the level above. This is a 42, 43-year-old female who's a security guard, works at our hospital. And, she was very, very symptomatic, bilateral pars defects, and so we proceeded to perform the operation. 19 millimeters of listhesis, 16 millimeters in extension, 19 in flexion. And so I like to place the wires first, and then I go in with an 18 gauge, 8 inches needle, which is used for endoscopy, prior to making my incision for the cage placement. Why do I do that? I measure everything, and I calculate my entry point based on what Hamid, Dr. Abbasi has taught me. And I also use sometimes the endoscopic way of getting into Kambins, and I mix both measurements. But then before making the incision, I take what I think is the correct entry point, and I use the needle to guide me to the trajectory and tell me that indeed I am going to be able to get in there. I find this extremely useful, and I would encourage people to incorporate it when you're not sure where to do the entry point for your incision, especially in those cases with a little bit of morbid obesity or some anatomical variations. And the rest is the same: working channel, the distraction, and preparation for your cage placement. We obtain a decent reduction. This is a lateral listhesis case that Dr. Abbasi kindly requested me to show. This is a lady that had a laminectomy with facetectomy done by another surgeon in our city, who, when the patient failed to improve and basically collapsed, he decided to do a spinal cord stimulator. Patient came to us, and looking at these films, well, we decided 2 things. One, the spinal cord stimulator needed to come out because it wasn't really working, but then she needed stabilization and correction of her coronal deformity. So the easiest, simplest way was an OLLIF, which was accomplished in approximately 25 minutes. And the patient did very well, and her clinical symptoms resolved. I'd like to, conclude the talk with basically three great areas here. One is the learning progression, right? So you need a hands-on proctor, and Hamid guided me through approximately 12 cases on a hand-to-hand basis. And, you start at single levels, L4-5, you progress to simple L5-S1, maybe a couple of levels with no deformity, and then you go to your grade 2 spondylolisthesis, whether 4-5 or 5-1, and maybe some coronal deformity. Your operative pearls, that I would like to share with you, the use of that spinal needle has proven to improve my precision in the entry point. Obviously, obtain perfect x-rays. Do not conform with just suboptimal x-rays. Retarget your trajectory. If you're not happy with the wire placement and you think your cage is not going to be an ideal spot, just go back and do it again until you feel that you have the ideal trajectory. In some cases, we've been completely unable at the L5-S1 level to get in there for reasons A, B, or C. And what we did in one case, we distracted after placing the pedicle screws, and then we did the cage placement afterwards. And I shared that with Dr. Abbasi about a month ago. I've done about 200 cases in the span of 3 years, which kind of correlates with Dr. Grunch. Her experience was about 600 cases, 6-7 years. So we're doing the same, about 10 a month, more or less. And I think, the progression has to be a common sense approach, right? So you can't start with grade 3 spondylolisthesis. You got to go from basic to more advanced. So careful patient selection, talk to your patients, manage their post-op expectations, tell them about the radicular pain on the left leg, obtain every single time the same type of preoperative film. So MRI, CT, AP lateral, flex X, and of course your bone density. I don't brace my patients. I early mobilize them. I try to get them up out of bed the first day of surgery, the same day of surgery, even if they stayed 24 hours, because some insurance companies are forcing us to admit these patients overnight. And so in those patients, I make sure they get at least 3 sessions of PT before they get discharged. I always follow my patients at 2 days. I like to clean the wound 2 days after with ChloraPrep and put a new dressing. I know it sounds a little OCD, but I like to see these patients, especially because they're being discharged so quickly. It creates and reinforces your bond with them. So follow up at 2 days, at 2 weeks, 6 weeks, 3 months, and 6 months. If they're doing okay after 6 months and CT scan shows good hardware fusion with no signs of issues, then we just proceed to discharge them. Overall, my experience with the OLLIF is that it has transformed my practice, and I'm very, very grateful to Dr. Abbasi for everything he's done in teaching me this wonderful technique.
Thank you very much for your elaborated discussion. Thank you.
Well, before we start with the next, thank you, Jaime. It has been truly my pleasure to watch you, how you have become a master of this. And let me tell you, you said you start doing grade 3 spondylolisthesis after 120. I started grade 2 spondylolisthesis after 720 cases. So what I'm proud of, that how you could absorb the knowledge and build on it so efficiently and so fast. And this learning curve, I need to emphasize, that is what Kambin Society needs to do. Pass this learning curve, make it efficient, because once we finish our residency, we go to real world, we don't have no time. We go to Vegas, we go to a lab for 4 hours, and then go on a roulette table for 12 hours, and then come back home and we try to learn and practice new things. This cannot be done that way. You need to have a proctor. You need to, and you said, I've scrubbed with you about a dozen of cases. This is not really much. You see, and this is something that we should expect, that go through a number of the cases until you absorb the basic. But then it's more than that, Jaime. You and I have been in contact. There's not a week that you and I don't exchange knowledge back and forth between us. And this is what have made you a master of one of the 3 people I know that including me, that doing grade 3 spondylolisthesis in L5S1. This combination, this cooperative work between us has gotten all of us here, and I'm thankful for that. One last question I have for you. Do you want to comment on some of the, especially younger colleague of ours, they look at the grade 3 spondylolisthesis, they are so ideologic about it, correct it to 0. What do you think of the danger of correcting a grade 3 spondylolisthesis surgically to grade 0?
Yeah, so I think that the nerve has, as we could see it, this patient has lived for approximately 5 years with the nerve in a specific position. If you suddenly bring that nerve to a completely different position, you're probably going to irritate it even more and cause a neuropraxia, a neuropraxic injury by traction. And the orthopedic standpoint is perfect lordotic correction, but as you have pointed out in the past, people don't sit down in perfect lordosis. So the concept of perfect correction, I just have to disagree with that idea. I think we got to bring patients to a better place, not to radiological perfection. I think we just have to get them clinically better in a construct that will last them the longest possible without the need for revision, period.
Fantastic answer. And I think you are you're the follower of the same school. Correct the patient, fix the patient, treat the patient, not the picture. So Thank you more for your presentation. Fantastic and a wealth of knowledge. Now, Dr. Aya, I think you don't need to introduce me. I think I'm if I'm not mistaken, I'm the next presenter. So, Jaime, if you could unshare your screen. I'm going to start sharing my screen. Thank you. So, without further ado, let me talk to you about some of the techniques that Dr. Gasco has presented to us. But as well, I want to go back a little even farther back and say that we have obviously lots of patients need a lots of help. And when you start with easier cases, obviously, but then you progress and you can do more complex cases. And I'm hoping that Dr. Gasco and I, myself and Dr. Schell and everybody here can help future candidates, future surgeons, to not make the same learning curve, but add to our learning curve. And this is what my talk is about, doing complex cases. Definitely, these are not things you will start with. And now, Kambin and Trans-Kambin, the Kambin triangle and Trans-Kambin approaches are now a fashion, are becoming a fashionable things. We talked about what you can achieve, and I just want to emphasize, you can do this surgery with a handful of tests, handful of tools, and if you can master this handful of tools, you can truly do magic with your skills. And we talked about that. Thank you, Varun, for visualizing that. People ask, can you do discectomy? Can you prepare end plates? Yes, if you get experience in that, you can do all of that. But more importantly, I think, you can do place, as Dr. Gasco was alluding to, you can choose where you put the cage. You can choose to put the cage in the front, in the back, in the right, left for sagittal and coronal deformity. You can influence the location of the cage, and that can help you. Now, there are techniques that I'm not going to go in depth about how you can do that. That's another talk, so stay tuned. But practically, one of the things you can do, you can control your whole environment and do given cases that Dr. Gasco was showing to you. And obviously, those grade 2 L5S1 should not be the first 50 cases, but believe it or not, you can get there within no time. Now, I want to talk about a few things that there is this learning curve we talked about. Is for each, we have made a science of it. For each of these procedures, that new procedures that you do at the next level, grade 2 spondylolisthesis, each of them has its own learning curve. And this learning curve, it's about 10 to 15 cases. It's not many, but we should expect that we cannot start this and expect to do a 4-level fusion as our 8th case. Okay, that is important. Now, one of these advanced cases that we have published a paper about is the transfacet OLLIF. And again, when I started doing OLLIF, in my first 100 cases, half of the L5S1, I have to open it, do it old-fashioned way. So we actually created a setup in the ward that we go from OLLIF to open in 5 minutes. Now we go in 3 minutes. In 3 minutes, we can go from OLLIF to do an open surgery, but the setup is important. There are lots of information that I will be able to share with you later on about how to set up the surgery from the start, that if you need to go OLLIF, from OLLIF to open, it takes you literally 3 minutes. So the threshold to do the safe thing to go to open is lower in the transfacet OLLIF. But then we came up, at the beginning, in the first 100 cases, I had to convert half of those 5S1 to open, but then I noticed I'm getting better, but I didn't accept I'm just getting better. I analyzed the pictures, and then we came up with a method that we published a paper in 2017. Practically, that method is a prone lateral for 5S1. Years before the prone lateral was a big word, we have been doing that. There's a paper that we published, and we will share it on our Kambin Society meeting with you. But then still, I had to do 2 to 4 cases a year, still go open. Since 2018, when we started doing transfacet OLLIF, and 2019, we published our paper, I did not need to open any of these cases anymore. Practically, in the facet OLLIF, you are still doing an OLLIF, but the hypertrophied part of the facet, you drill it down to create your approach to the Kambin triangle. And practically, you have to make sure that your trajectory is fixed in the method you want. You have to be a master of this instrument. And then you drill while you're stimulating under 12 milliamp, 10 to 12 milliamp, the whole instrumentation, and you drill, and you're in the axilla of the L5 nerve root and the S1, and you go in and you're stimulating at 10 milliamp. So practically you would know if you are there. And here is a video of it. Let me see if I can run this for you. Practically what you do is use a stepwise drill. You fix the trajectory. Once you fix the trajectory on the hypertrophied part of the facet, you use a series of drills to drill through the lateral part of the hypertrophied facet to literally open up the Kambin triangle. Now, this is still not a transforaminal TLIF. You're still truly in the Kambin triangle. Again, we have published a paper. We have a lot of videos in the sense of that we should be efficient. I'm just going to go to the next slide where you see actual X-ray of this procedure. So I'm going to explain it to you. You practically, I still use my neuromonitoring tool. I put it on the area that is practically give me an exact, no, the first thing is I put a Jamshidi, get the bone marrow, and here you see the trajectory that would take me to Kambin triangle and to the disc. Then we have a better method now, but then here we put a small drill, a two-step drill that first the dilator, then the tube, then a two-step drill that we drill little by little under 10 milliamp of stimulation until we get through the bony structure. As you see here, the tube and the drill are advancing at the same time, and you see now the K-wire is entered to the Kambin triangle. Now here you see you are pretty medial, and that enables us to put the cage quiet in the central position. Now, this is practically a backup technique if you cannot get to L5S1. The safety profile of it is much better than if you cannot get the right angle and have to push the nerve to the side, because as you see, you're truly in the axilla of the nerve between L5 and S1, and nature, God, evolution gave you a free pass here. So I will talk in one of our next meetings more extensively only about this, but we have a few other things I want to show you. So I will proceed now to the next slide. Now, this is the same slide, so I'm not going to go through this. So let me go to the next slide. Now, one of the other things that I want to talk to you about is that so-called expandable cage. It makes sense, at least originally, to have a lower profile cage that when you are in place, you can expand and create more decompression. Now, all the problem with these things are that they have lots of intricate pieces. Number one, you cannot pack inside with the biologic. Number two, those intricate pieces, by the time you really want to provide the pressure you need, at least in my hand, 1/3 to half of the time, they fail you. So even though I love the idea of expanding the place, these cages never worked for me. But what did work for me is using the static cage in a lower profile, go through the Kambin triangle, because superior, inferior, you're confined by bone. But anteriorly, which is where the nerve root is, the nerve root can float more. So if you put the cage in the lower profile, literally 90 degree, and then once you're there, you turn it 90 degree, then you go from a static cage to an expandable cage with no additional complication or no additional pieces, internal pieces. Some of those pins in this expandable cage are 0.5 millimeter, and you have to provide lots of pressure with a pin that's so small, so they can fail. Now, let me show you actually a picture of that. So practically, you go in the lower profile. Once you're in place, there's a specific technique. Then you literally, you turn it 90 degrees. But then once you have done that, you advance it few more millimeters so that it's not resting on the same place, as you see here. And there are some other videos that can show you actually that as well, how this works. That is another advanced technique that can be utilized. One of the other advanced technique that I want to show you, and that I'm hoping, that with the more experience you can get into that, is uses like this, where using the K-wire, like what our interventional colleagues do, and put a small bend on the K-wire and pass over the osteophyte to enter. You see here, we go here, we put a small little bend on the K-wire and use the natural trajectory of the K-wire to get in the very difficult spaces. I want to show you the on the X-ray. Here you see that if you are coming in with the neuromonitoring probe, and we put a small little bend, then we use the bend and turn the bend of the K-wire in the direction that's more suitable. Once we are there, then we can put it into the disc base, and the dilator does the rest of the job for you. Our interventionist colleague has been using it for a very long time and with some good experience, but you have to have good dexterity with this set of tools before you use this technique. Now, I'm going to move on to one of the other things that I want to talk to you about. And that is, let me see, in the collapsed disc, I just want to quickly show you, even in the most collapsed disc, once you get the dilator in, you can actually use the dilator itself here to open up the Kambin triangle. So the Kambin triangle, it's not a fixed base. You can enlarge in it. And our advantage is that the nerve root is very close to the lower part of the pedicle. Once you're increasing the size of the Kambin triangle, you're pushing, as Dr. Agarwal pointed to, you're pushing the nerve away and enlarging the triangle. So one of the last advanced kind of things I want to show you about, and by the way, and then once you're a master of this, you can do really many cases that you wouldn't think you can do. Here you see that patient has a huge osteophyte, and once you are a master of this instrument, you can actually put your instrumentation on the osteophyte, enter it, and actually use that to lift up, to compare that how this is now before and after. Not only you're increasing the interpedicular lateral recess and foraminal space, but as well by eccentrically putting the cage in, you're correcting the deformity. Yesterday, in my surgery center, we did a scoliosis surgery on a patient with BMI of 48. We did that under 1 hour. Patient went home in less than 2 hours after surgery. And this was a patient that 2 other surgeons said, because of the BMI, they couldn't help this patient. So not only we did that, we did it in our surgery center on the BMI of 48 and sent the patient home less than 2 hours after surgery. And that is the power that everybody in this group is now alluding to. Now, one of the last thing I want to show you today is the so-called, we are going to talk about posterolateral fusion. I'm not going to talk about the OLLIF cage retrieval. That's a matter for another conversation. But posterolateral fusion. Now, obviously, in the Trans-Kambin approach, we are relying on interbody fusion, and many of you have alluded that you can do discectomy, you can prepare the end plate, and the fusion happens a lot faster if you don't destroy the vascularization of the spine by stripping the muscle from posterior element. But what about posterolateral fusion? Now, obviously, we start the surgery by putting a Jamshidi and a K-wire in the disc space. And then our device, and I'm encouraging you, connect to us. We are happy to share this information with you, is an eccentrically positioned dilator that goes, and the tip of it literally centers on the facet. We grind the surface of the facet and then put biologic here. and then put it in that pores that we just opened. And it takes about 30 seconds per facet to have additional posterolateral fusion. So, and here you see the work of this, and I want to show you one video. And there are additional instruments if you want to be more aggressive. But I actually going to stop here. But if I can find the video, I want to show you an actual video of how this the so-called the transfacet fusion works, because it is a very easy process that we can show it to you, and this device we can make it available to you if you wish so. And I just want to see if I can find a video that I can show it to you quickly in few seconds how this transfacet part works. So I'm going to look for that video. It's online, but for lack of to be efficient with our time, I would pass it to Dr. Anjem for the next presenter.
Thank you very much. It's always a never-ending history. When you start talking, it's so much to learn and so much to ask. Thank you very much for your
Can I speak something?
Yes, please.
Can I speak? I am M.K. Shastri. Hello, can you hear me?
Yes, we do hear.
Sir, by seeing your approach, I always see, I have seen a century in a minute. And I've seen thousands of spine surgeries, but I feel if this is done, you are in another world of spine surgery. Every word what you are speaking is a parable of Bible, and this is operated. I think large number of deficits. Spine surgery is never a horror. When I see a spine case in India, people are worried to see a neurosurgeon also, because they have so much horror about any small a small part of spine to touch. But if this is done, I think spine surgery is heaven. You have made hell in heaven.
Thank you.
And Dr. Abbasi, I will always say, you are angels of the angel, because you made a most difficult subject the most easiest one. The way you have touched, the preciseness, the modifications, and I don't know, how did you analyze this thought? And that is the reason I said, Farah, I want to learn, how did you think? And that is the reasoning what we must learn from you, sir.
Thank you very much. I'm very humbled. I'm honored to hear that. Before we move forward, though, I found that video that I want to show you in 10 seconds, the so-called facet decortication. As you see here, are you able to see my screen?
Yes, sir.
Oh, the tube and the dilator is eccentric. The outer tube has sharp edges. It goes in and it grinds the surface of the facet on both sides, superior and inferior. And then then the inner part comes out, biologic goes in. As you see, inner part is out, biologic goes in, and then we tap that biologic in the pores of the superior and inferior facet that we have created. And practically the entire process is less than 30 seconds per facet. And you don't need to go down in and drill anything and so on. The tips are very aggressive. You just have to be careful not to be too aggressive, because then you may grind actually completely through the facet. So I'm stopping here. Dr. Anjem, we have a fantastic faculty here. I'm sure they are waiting for their turn.
Dr. Abbasi, one thing I like to say you keep speaking for 24 hours into 365 days, and it is never complete Bible.
Thank you.
The way you have taught this subject in such a precise way, I feel I'm one level up.
I'm humbled. Thank you. I appreciate that.
I should be obliged to you, sir, for making such a complicated thing, such a simple, that even a layman can understand. I thank Farah for arranging everything, and I'm very happy that I'm meeting you in India, sir, and really obliged to you.
My pleasure. Thank you.
Thank you. So we will move to our next speaker. He's waiting for long, I guess. So Dr. Hamid R. He is neurosurgeon in Durham, North Carolina, and he's expert in treating neck pain, spine problem, and spine fusion. So I would like to request him to talk about optimizing Trans-Kambin surgery.
Well, let's see if Dr. Albar is here. If not, we go to the
Yes,
next.
he is there.
Oh yeah, I see. Dr. Albar.
Yeah, yeah.
Oh, he's muted.
Have you admitted him? You have to admit him.
Oh, he's admitted. Everybody's admitted. I think he has silent. He has muted.
Sir, can you check if he has the access to our meeting?
Yeah, check the iPhone on the panel to enter.
Well, he's actually admitted. He's actually admitted. I see him on the list.
Okay, you see iPhone on the list?
Yeah, I do see him on the list, and I see that he's admitted. He's just silent. Maybe he has some technical difficulty.
Sir, should I, send him a message, a
Yes,
personal
please.
message?
Why don't we go to the next presentation while we are working on that technical part? And Dr. Bashir, please connect to him, see what the technical difficulty is.
Yes, sir. I'm just texting him right now.
Okay, then Dr. Anjum, please let's move.
Yes. Sir, our next speaker then will be Dr. Hazem Nicola. He is now working in Quito, Ecuador. He's an orthopedic surgeon and a specialist in minimal invasive spine surgery. So I would like to know a little bit about deformity correction with Trans-Kambin OLLIF through his own experience, please.
Hello, Hamid. Hello, everyone. Thank you for your invitation.
Hello, sir.
And you see in my screen?
Yes, sir.
Yes, perfect.
So it's a pleasure to be here because I am one a little bit different from others, and Hamid knows that because I am a new adopter. I've been correcting adult deformity with other techniques like OLLIF and XLIF, and now I have like experience with that kind of techniques, and now I'm gaining new experience with the OLLIF and the benefits of doing a faster, safer, and getting almost all the same results as in the recent past. So yeah, my talk after that introduction is about deformity correction. I won't go over the technique because really you have talked about a lot about that, but yeah, I want to talk about what benefits I see in terms of deformity correction and what we can do with the OLLIF technique and segmental correction. So as an introduction, there is a lot of literature talking about the anatomics of the Kambin triangle. You are all experts on that space, but I love to see that picture that I have in the slide, and then I highlight the size, the mean size of the base of the triangle in cadaveric studies, and it's not a small space at all. And mostly in L4, L5, L5S1, we can manage to use this approach to insert a cage, an arrow cage, the same size or sizes, big sizes, like we want to achieve not only correction, then again the indirect decompression that I really a believer in the indirect decompression. Then I will focus on, of course, in adult deformity because the objectives and symptoms aren't the same, and we all know that. I really believe that we have to combine. I heard that I'm totally agreed that we don't operate on X-rays, but we can't forget about sagittal balance and the importance of sagittal balance in adults or even in adolescents, but in adults I think it's key. and differentiate between segmental correction and global correction, and if you need to go to pelvis or not. And again, sagittal balance for me is important, and I really now believe that I can do the correction of sagittal balance with OLLIF technique, as well as when I did in the past A-lifts and X-lifts. So a fast slide. I always ask for long cassette X-rays for all my patients, even if it's one level spondylolisthesis. And well, I always encourage my residents to learn about sagittal balance. All the angles that are published is very an abstract concept, but there is always a way to understand and know what is pelvic incidence and know what is lordosis. So in countries like Ecuador, you don't always have the resource for a long cassette X-ray. So I ask patients, and I encourage my residents to ask for maybe a lumbar X-ray with including the hips, where you can assess a little bit more exact the spinopelvic alignment. So why you can ask yourself why Dr. Nicola is trying to or bringing this presentation, and why he's moving, because really I've been doing well with A-lifts and X-lift, but our techniques that when you talk about complications and time of doing this, it's a little bit different what I see with my short experience with OLLIF with Dr. Abbasi. So like you see, there's many articles talking about complication in surgical intervention for alto scoliosis. You see the high rates of complication. You have to look for this patient maybe are high morbidity patients, senescence, frailty, and bone quality is very important to take care in this kind of patient. There is another publication that I like to highlight, because it separates the complication between the diagnosis, neuromuscular scoliosis, adult scoliosis, and idiopathic. You see that the higher rate of complication always is adult scoliosis. Another article talking about this topic and highlighting the seed arthrosis, the high seed arthrosis in that kind of case of posterolateral only cases. And this is a high multi-center study that I love, and I learned a lot with this presentation. And they talk about perioperative and delayed complication, and look at the high level of revision surgery required after a posterior only surgery in adult. And that's one thing that make us think what to do to improve that. So let's talk about what is really indication for correction in degenerative scoliosis. Not of course, not all the curves are needed for surgery. Okay, if you don't have symptoms, of course, and the balance of the patient is not that bad, you don't need surgery. But once you need surgery, what are the options? I like to go over the OLLIF and the MISD-LIF, and this is the trajectory. And when you see an actual view, this is the spectrum of the disc that you can use to correct deformity with OLLIF. Okay, you have almost all the disc from the point of view of the Kambin triangle. And when you see the coronal view, this is an example, what you can get. You can position the cage, like everybody says that has more experience than me, in the best position that you planned in the preoperative planning, and you can achieve a very good correction of the sagittal balance and the deformity itself. This is the sagittal view, an example of what you can do. You can position a big cage, enough big cage, and of course decompress and recalibrate the spine in a good way with the OLLIF. And this is the one that I like more to show, because you can position the cage in the middle, in the front, or even in the back. We've done some cases in Quito, and that's one thing I liked about this technique, because Dr. Abbasi, I told him we're going from the left side, and I'm worried because the compression is in the right side, and he told me we can go as right as you want. You can position and decompress directly, almost directly, in the other Trans-Kambin, the other side Trans-Kambin space, and it's like that. So this is an example where you can position. I won't go over that because you have more slides and more x-rays than me. Example patient. This is an example of a case done by Dr. Abbasi, and you can see how you can correct the coronal balance. This is another case. And this is important to see. The segmental correction. This is the concept that I like with Trans-Kambin OLLIF. And you can go over a scoliosis, and level by level you can get a segmental correction and then achieve a fair correction for the patient. And maybe in some cases you don't need to go for a T10 pelvis surgery, as is like a pandemic thing that we are seeing in the present. This is another case example, a patient with a 4-level correction of his deformity. And then, well, this is the measures to take always with minimal invasive, specifically with OLLIF. You preserve the posterior elements and reduce the postoperative pain, and increase the recovery of the patient. You can do with OLLIF a very, very good height restoration of the disc, even for correction of deformity, and of course indirect decompression of the neural structures, and reduce approach morbidity, because all related with minimal invasive surgery. Thank you very much.
Thank you very much.
If I may, I love your talk, and especially those slides. I mean, those are fantastic. How to present, you present with single slide this anatomical fact that we know, but this visualization is fantastic. I'm really proud to having this talk on our meetings today, and I know that you will add to this talk, and you will be teaching that as well to many others. So thank you very much, Dr. Nicola.
Thank you very much, Amit.
It's really wonderful to hear you, and you have touched another level of decompression. And when you see this type of surgeries, you see that you are in heaven. And another credit goes to Dr. Hamid Abbasi, that he is creating heavens in earth. So I'm really happy, sir, to see such a beautiful talk and such a beautiful presentation. I'm really obliged that in just a few minutes, we have encountered centuries of spine surgery in few minutes. Thank you so much for your beautiful talk, sir.
So I would like to ask now Dr. Muhammad Bar. He's a neurosurgeon in Durham, North Carolina, an expert in treating neck pain, spine problem, and spine fusion. So I will request him to talk a little bit about optimizing Trans-Kambin surgery.
Thank you so much. And thank you, Dr. Abbasi, for the wonderful invitation. And thank you to all the speakers. I learned more in the last hour than I learned in all of fellowship. So, it's always great to be on these webinars. You're asked to teach, but you actually learn more just from being here. So today I'm going to talk a little bit about patient-specific anatomy. And it was great to see Dr. Abbasi talk about the transfacet approach, and we'll describe that as well. Here are my disclosures. So we're going to talk a little bit about 3 types of TLIF. The traditional MIS TLIF that most of us were trained on. We're going to talk about the Trans-Kambin percutaneous TLIF. Then we'll talk about the transfacet TLIF. We're going to talk about indications and limitations of each of them. And then I hope to talk about the patient-specific TLIF, and then my current algorithm of deciding which type of TLIF I'm going to use. So if we look at the different flavors of TLIF, most of us have been trained to do either an open TLIF, where we do a hemilaminectomy, we find the theca, we push it to the side, and then when we do it under a tube, we call this a MIS TLIF. But if you're trying to put a big cage in there and you have a little small nerve, you can get a CSF leak or a nerve root injury. There's not much room within a tube. The next option is this transfacet pathway. For some of us, this may be difficult because it's, maybe foreign to us. And then the last one is through Kambin's triangle percutaneously. And as people have really talked about, Dr. Parviz Kambin was a real giant that we owe a lot of gratitude to. I think that Dr. Wang in Miami have done a good job talking about it being a three-dimensional anatomical place, and it should be called more of a prism. We did this systematic review looking at Kambin's triangles, mostly using anatomical structures. And we found that as you go caudally in the spine, you'll find that the Kambin's triangle area increases. And then as our endoscopy folks will tell us, if you do a foraminoplasty and take off this part of the SAP, you can actually double the size of Kambin's triangle. One of the key things to realize is that, that was done anatomically, but as surgeons, we deal with pathology. And so if you have a disc herniation and or a spondylolisthesis, that area can actually decrease. Now, a lot of the work was done using anatomical structures or CT scans, but as other speakers have spoken of today, what's critically important is that exiting nerve root and the DRG. So what we did, my background is in neurosurgery, so we actually went back to the cranial software, the BrainLab software, and we started to map out the nerves individually. And then we can actually measure preoperatively using standard MRIs how big Kambin's triangle is. And so if I don't have to do a direct decompression, I can always choose the side of the larger Kambin's triangle. We also found that you can know the traps before they come here. So here's an example where we're able to see before surgery that there's a conjoined nerve root. So we're not going to go through Kambin's triangle there. If you take the nerve into consideration, we showed that that will actually decrease substantially the area that you have. So now it makes us even less confident. And then we found that for some people, Kambin's triangle is just too small. This one here, we measured a maximum diameter of 6 millimeters. So that's going to be too small. And so now we know this, so we're not in the operating room, floundering and having problems. We can actually know before we go to the operating room, this may not be the best case for a percutaneous TLIF. And so then we started to use the transfacet corridor. And so this is something that was popularized by Zach Ray at Washington University in St. Louis. So here we are. This is caudal, this is rostral, this is the IAP, this is the SAP, and you stay within this corridor here. And so we mapped this out using our MRIs again. And so we could see, that this transfacet pathway, we could compare it at each level, and we found certain interesting things. This paper was just published this month. You can look at the area of the corridor. We found that in general, the transfacet corridor will be larger. And you can look at the maximum permissible cannula diameter. So when you're thinking about putting a cage in and so on, you can actually decide, what are the maximum dimensions of the cage that you're going to put in. We found some very important things. We found number one, similar to Kambin's triangle, the area increases as you go up, as you go down the spine, however, and this is really important, is that when you have a pathology like a spondylolisthesis, the transfacet pathway actually gets larger because that joint, it gets diastased and you have a larger working area. So it actually becomes safer with grade 1 and grade 2 spondylolisthesis. We also found that no longer are the nerves the limiting factor, but in fact, the posterior disc height is the limiting factor. So the area actually is big enough, and so you don't actually have to worry about the nerves. You only have to worry about the posterior disc height being your limiting factor. So here is a case. This is a 30-year-old gentleman with a grade 2 spondylolisthesis. You can see here he's not a good candidate for an ALIF. He did not want a lateral surgery. So what we did for him is we did the segmentation. We planned out this trans-facet pathway. You can see here we're avoiding the exiting nerve root and the traversing nerve root. We put in the screws, and then it's my standard operating procedure to get a CT scan, make sure my screws are good. And then we're actually able to merge the intraoperative CT to the preoperative MRI. And then as I'm drilling in the transfacet pathway, I have this augmented reality or heads-up display telling me where I am and make sure that it's safe. And so right now, we're manually segmenting out the nerves, but we're working on automating this so that it can become in anybody's armamentarium. Now, you would correctly say that, while with the Trans-Kambin, you're not really decompressing. The MIS TLIF, you can decompress. And we showed that, it does make a difference for those people that have the percutaneous TLIF. They use, 40% less opioids, and that's really important. And I think a lot of the other speakers have talked about this. So for me, that's where I got into endoscope, is that maybe there's a way to kind of bridge those two gaps. And then not only are we doing patient-specific trajectories, but we're also doing patient-specific implants. So you can see here, these implants now land very nicely on the end plates and don't cause subsidence and so on. So here's another case, case that we see a lot, grade 1.5 spondy. So what we do for this person is we measure their Kambin's triangle. It measured at 7 millimeters. We measured their transfacet pathway. That's 11 millimeters. I felt more comfortable doing a transfacet pathway. So that's what we did for this patient. So in terms of our current algorithm, I do a lot of ALIFs, I do a lot of laterals. If it's a significant deformity, though, I think that Dr. Hazem's work is great. I think that for most cases, I'm doing either an MIS or hybrid anterolateral approach if it's more than 3 levels. If it's 1 or 2 levels, maybe 3 levels, I'm measuring this Kambin's triangle. And if it's big enough, if it's not big enough, then I'm going to have to use the transfacet pathway, which Dr. Abbasi talked about, plus or minus a decompression if I need to do a direct decompression. If the Kambin's triangle is big enough, then I need to think about whether I need to do a direct decompression or not. If I don't have to do a direct decompression, I think this is the perfect case for the Trans-Kambin percutaneous TLIF, because I know Kambin's triangle is big enough. I don't need to do a decompression. All I need to do is decrease the spondylolisthesis and do a indirect decompression. If I do need to do a direct decompression, there are actually 2 options now. You can do the Trans-Kambin perc TLIF with an endoscopic decompression, or you can do the transfacet TLIF with a decompression, most likely tubular, since you're doing that. So just to conclude, I think that TLIF is a really powerful technique. And I think patient-specific pathology and pathology-specific planning is extremely important. Thank you so much.
Well, thank you so much, Mohammed, for this fantastic talk. And I just want to comment on that I have to give you a historical perspective on that. We used to do vaccination long before we knew how vaccines work, and we start, doing it as we do it today. But once we knew the basic science of vaccination, that we could really change the world. And Mohammed, what you have been doing is basic science of this approach. And I'm very proud of what you presented today here, because with your knowledge, obviously the people like me and many others, we have been doing it like the time that people were doing vaccination, taking a smallpox from a cow, putting on people, knowing that they do better. But your knowledge that you're gaining in your basic science of this approach is what going to make truly the difference in the next 5 to 10 years to really bring that to mainstream. So I'm really thankful personally to what you do, Mohammed, and thank you for your fantastic talk.
Thank you so much.
So my screen is visible now. I want to present now a case from Dr. Ajay Krishnan.
Yes,
Is my screen is visible?
yes, we do see you.
Wait.
Sir, should I contact Dr. Krishna?
No, I have his presentation. I just have to present it.
If you like, I can run it on my side. I can have a bigger screen if you like.
You have to just
Okay,
play.
sir.
Yeah.
Hello, everyone.
Yeah. Okay, sir. So, yes, sir.
Hello, everyone. Top Trans-Kambin EPLIF and have evolved to a new paradigm of PTLD. This is one of the few stories which I have seen over the last 20 years. In this patient, an operated patient of endoscopic transforaminal decompression surgery under local anesthesia, patient went back to Saudi Arabia. And this patient in 2014 ended up reporting to a major newspaper in India that his leaves are not sanctioned. The medical board has rejected his claims because there is no surgery being done on you in spite of the MRI which has been done and to prove. And there is no surgery which is possible through a pimple-alike scar. And then finally we had to intervene and get his claims passed. So that is the story which is there, and many number of stories have happened with me. And the spine surgical revolution is endoscopic spine surgery. We all know that, and we do it painless, stitchless, and awake. And the renewed interest is more towards the Kambin's approach. That's why we all are here. Let me take you back in the timeline 2008, 2009, when I had started doing PTLD. With the initial jolts, I matured to a good outcome giving surgeon, and luckily it has worked in my hands and in many hands. And further, we went on to explore to newer possibilities, because as knowledge, skill, and technology evolves, extrapolation of the acquired confidence into other possible applications starts. Let me take you through this case of 71-year-old male, a 9-month back pain and right lower limb radicular pain. He was elderly. The ODI was 86, which was there. And what you see is a lateral canal stenosis with facetal arthrosis, a facet tropism there, and a grade 1 listhesis. And this patient, we subjected him to, under local anesthesia prone position, a transforaminal approach for endoscopy. And in that endoscopy, we could succeed with the cannula in place there. And this was the final thing, what you can see there with the decompressed traversing nerve root there, and all the endpoints of the decompression achieved under local anesthesia. And with this, we have already published the endpoints of decompression in lumbar transforaminal endoscopic surgery for all patients which we operate. We didn't stop in this patient at this point. Look at this, because he had mechanical pain, we were to go for fusion. We injected the medicines for the epidural anesthesia and went on ahead to do the preparation of the end plate. Look at the picture in picture here. See the wand moving. This is an Inspire gun, which was a borrowed instrument from one of my friends, and we had used it to prepare the disc space there. And we had placed the percutaneous guide pins for the screws also under regional anesthesia. And this is what is the Inspire, which helps us to prepare the end plate. But it took us nearly, with this, around 45 minutes to 1 hour to prepare the end plates only, and we could acquire a good prepared end plate. That is fine, but where is the bone graft firm? And we had an indigenous way of getting the bone graft, and I put a hollow mill-like thing which is into the iliac crest, as had been doing a lot of pelvic surgeries at some point of time, so knew the trajectory, went in there and harvested the bone graft. And this bone graft, what is harvested, is from 5 to 8 gram easily, what we harvest by multiple attempts. So these cylindrical cubes are what we get, and we add with this hydroxyapatite bone graft substitute, and on that we then just put it into the cannula and pack the space with bone graft. And once that is done, the screw insertion is completed, and this is how the final picture of the patient. And this is the image of the patient with 4 screws inserted, and this is the entry point for your transforaminal. This is the percutaneous harvested bone graft, and this is 9-year follow-up of this patient now. And I've been very vocal about it. I presented it multiple places, including MISAPCon. In 2016, I went to international format and presented it there also. And finally ended up publishing in 2018 a 13-case series, but as a feasibility study. Mind you, as a feasibility study. It was 13 patients. The patient-reported outcome measures were exuberantly good. Satisfaction was immense. Fusion achieved in all the patients, and the disc height loss was minimal, and there was no dysesthesia even transitory in this patient. But look at this conclusion. The conclusion that was that it is not appealing to be recommendable to general population in spite of it being low cost and negligible complications. Further research was needed with engineering tools for reducing the operating time. So what was the crux? The problem was this. The operating time average was 250 minutes for decompression and fusion both to be achieved, and the tolerance score was not which was happy about to be. That's why after nearly 27 cases, I stopped doing this procedure in that point of time. And the questions which remained unanswered at that point of time was, I didn't have better engineered tools. I couldn't expedite the procedure more. I didn't have biologics. I didn't have that cages at that point of time. I went on exploring further and doing good work in transforaminal surgery to evolve to stenosis surgery being decompressed under local anesthesia, even cauda equina syndrome being decompressed with great outcomes under local anesthesia. And this is the latest which we have is something on calcified disc. This is a 79 patient series of long-term outcomes. This is a patient of a paraparetic L1-2 which is there, and we did transforaminal endoscopic decompression under local anesthesia. You see this is the excellent decompression, and the paraparetic patient recovers under local anesthesia. That's what is the outcome of the transforaminal surgeries. And we all have this interest in transforaminal approach because we all now know that it is least manipulative, and as you go more ventral, it is least manipulative. And 2024, we have started revisiting and reinventing the things. Even I've seen the bipolar fluoroscopy being used by Professor Hamid, and we have started doing. I started doing under general anesthesia right now this procedure of Kambin single level fusion, and even my colleague Dr. Miran Dave, now he has done it under navigation under neuromonitoring. So we are evolving to safer parameters, and all this is because of one thing. We have kept the direct decompression aside and trying for the indirect decompression of the Trans-Kambin OLLIF, and the time is reduced by nearly 1/10 of what I used to take 10 years back. And that too in India, we may be able to do it probably awake, aware and alert, and maybe without neuromonitoring in soon. And that's why we are here for this more further progressive combined learning. Thank you. Thank you very much.
Well, thank you so much, Dr. Krishnan. You know, your experience, I think, has been as well reflected by many other surgeons that practically they have to pioneer the way. And I think with your help and our help together, the future surgeon will have smoother path to gather the experiences, and that is what the Kambin Society is. And I really thank you for your presentation, and it was very enlightening for me. Thank you.
Definitely. Thank you. Thank you.
Thank you, sir. So I would like to invite our next speaker, Dr. Neeraj Vasavada. He is India's leading spine surgeon, expert in minimally invasive and endoscopic spine surgery, and one of the pioneer in digital spine surgical technique.
Thank you, Anjum. Thank you, Professor Abbasi, for getting together all the stalwarts of spine surgery here. So as somebody rightly said, you know, I have been learning since this last couple of hours, much more than I've learned in my entire career. So thank you very much. So this presentation today is more like a philosophical talk that, you know, what went through my mind while adopting to a Trans-Kambin OLLIF procedure, which is a relatively new procedure in this part of the world. So what brainstorming I did and how I gradually went into further. So my perspective is I'm not an innovator like Dr. Abbasi. I'm an early adopter for a technique for sure. And he, as rightly said, Dr. Abbasi just said that I'm standing on a strong shoulders of the giants like Dr. Abbasi. I have nothing to declare. So my first attempt at being an early adopter talks about 2007, 2008, when the interspinous technology, swept away the spine surgery and everybody wanted to put interspinous devices everywhere. My 45 DM is still probably the highest in the country. But soon I realized that indications are extremely limited. And soon the technology went off the shelf in our country. So lessons were learned that not all that glitters is gold, and judicious approach and checklists are necessary in adopting a new technology. So why consider a new technique per se? So that there are some reflective questions one must ask to themselves, that am I content with current gold standard, which for lumbar spine is MIS TLIF or anterior to psoas or a trans-psoas approaches. So are we satisfied with that? The answer could be yes and no. We are doing since very long and we are very satisfied. But there are some challenges which we face. What could a new technique offer to my patient? This is probably one of the most important questions that I must answer before I adopt to a new technique. And as it is rightly said that scientific research is an almost constant pursuit for a better truth and not the truth. So we always have to continuously evolve so that we can offer better and better treatment to our patient. So what's not ideal in this conventional gold standard? So MIS TLIF, I feel that epidural space is invaded with equivocal violence as we do in open surgeries. We generally use smaller cage profiles, multi-level when it goes more than 3 levels, it nullifies the advantage of MIS when we are doing MIS TLIF. Foramina height restoration is much inferior to ATP approaches. When we talk about ATP approaches, it is unfamiliar approach to most of the orthopedic surgeons in our part of the country. It is restricted to a conducive vascular corridor, and complication can also be a catastrophe. Change in position sometimes is required from lateral to prone. And if you are doing a single position, you require a lot of expensive equipment like expensive 3D nave, and revision is always difficult. So my initial brush up with OLLIF, when was it? So whenever I look back, this was probably the first symposia with Professor Abbasi way back in 2022. And at that time, I did not know what he mean by OLLIF. And probably, that was the first time I encountered what it was. Then I came about endofusions and I thought, that is a different technique we are talking about. Then somebody was talking about Trans-Kambin fusion. And I was again confused that are we talking about the same thing or things are different? It was in Subcon 2023 when I personally met Professor Abbasi. And at that time, I came to know that this is a fusion which is happening from Trans-Kambin's approach, and all are the same name of same technique, but different name. And my first case very recently I did was in 2020-24. So I'm 7 months old with this technique. So before I adapt to new technologies, these are my 10 commandments, which I must follow before I jump on a bandwagon of a new technique. First, does this new technique incorporate the established concepts? Does it prove there are proven safety and efficacy records available for this technique? What are the resource requirements and can I match them? What is the learning curve which I have to go through, because I am a very average surgeon. So average surgeon has to learn this technique. What are the indications and contraindications? Is there a clarity about it? What about the availability of mentors? What if I get stuck? What if I have questions? If I have somebody to lean on, the giants on whose shoulders I'll be standing? What are the salvage options? What if I get stuck in OT, and is there a salvage option easily available to get out of that difficult log jam? What are the challenges and how to overcome them while adopting this technique? Is this technique peer scrutiny readiness is possible or not? Potential complication profile and long-term challenges must be discussed before I jump on the band. Let's look at one after another for this new technique. So the OLLIF or a Trans-Kambin fusion mainly banks upon indirect decompression, and which is a very established concept. Large cage has its advantage, and that also supports the literature. The Trans-Kambin approach is a well-established approach in literature, and endofusions and endoscopic papers are multitudes in literature. There are proven safety records and multiple papers himself, but by Professor Abbasi has been published, and full endoscopic people have the literature filled with this technique. So there is a proven safety and efficacy which is there. What are the resources are required? There are very minimal resources which are required. Most of the time, C-arm is sufficient. You only need OLLIF instrument cages and instruments which to perform the surgery. Which just now Professor Abbasi said that they are, his instruments are just, you can count on fingers. You require percutaneous pedicle screw fixation, and if you have 3D nav, that is an additional requirement. I per se prefer to use this procedure under IONM or a neuromonitoring. Learning curve is not steep because we are using a very familiar approach. We are tuned to perform transforaminal endoscopies, transforaminal epidural blocks, or a discography. It is the same approach what we are using. Once guide wire is in optimal position, rest of the instrument just needs to railroad on it. So learning curve is not too complicated. Clarity of indication and contraindications are always there in this technique. Almost all indications for indirect decompression are amenable to this Trans-Kambin fusion. Even when you have to decompress, it is much less invasive than the traditional MIS TLIF for open approaches. So this was my first case when I did, and I was amazed to see the surgical time of 2-level TLIF with including percutaneous fixation was less than 55 minutes. If I had done this MIS TLIF, it would have taken me around 2.5, 3 hours. So, I can reduce anesthesia time. I can make my patient quickly out of the OT. In fact, I tried to establish this the Trans-Kambin corridor via doing an epidurogram and just to check the safety. And you can see that, there is a wide Trans-Kambin area available to put your needle inside. So what were the challenges which I anticipated initially? Will I be able to adequately prepare the disc space? That is the first question I was asking myself. And when I did my cases, you can see the amount of disc material we could harvest from the small Trans-Kambin area. Almost entire amount of disc space was amenable to be removed. Existing nerve root injury or ganglion injury, which was again in my mind, whether I will be able to prepare end plate well or a damage end plate while doing so. And what are the salvage? Salvage was always an MIS TLIF. So what about, these 3 questions which I just asked? So I just want to take you through this trans-facet approach which I used in my initial cases where I did an SAP and IAP excision. I put my 16mm tube on the facet and just wanted to see what happens when I'm putting guide wire, what happens when I'm going through the cage. If you see in this image, this is the disc space and you see there is no exiting nerve root comes in a way if we have sacrificed even a part of superior articular process, and this becomes a very safe area. Then we talk about end plate preparation. You can see that end plate is so nicely prepared. You can very easily see bleeding bone. These tubes are just kept to see what is happening inside the disc space. We have not done anything with this. It's a classical Trans-Kambin percutaneous TLIF approach, and you can see the bleeding bone which is visible on the end plate. And this is the final resting place for my Trans-Kambin cage. So peer scrutiny, because it's an established concept, peer scrutiny is not a problem for this particular approach. Of course, there are potential worries. We are worried about some cases where alpha S1 requires special attention. When there is intertransverse corridor is very narrow or iliac crest is too overhanging on the space. And in those cases, sometimes we may have to go for the traditional conventional TLIF. Ultimately, I'm looking for fusion. I'm just 7 months of follow-up and I'm keeping my fingers crossed that, my patients will fuse. But I'm getting really encouraged to see stalwarts, showing their fusion rates here. So I'm hopeful that my patient will also show a good fusion rate. So far, my data, I have done 35 patients, 52 implanted level, no major complications, no exiting nerve root symptoms. Average operating time per level is now 35 to 40 minutes, including PPFs. Minimal blood loss. I use IONM in all cases with trigger electrodes to check safety of Kambin corridor. No conversion to MIS TLIF so far. No revision. But at a disclaimer, it's a too early trend for me and a very small sample size. I hope that I can replicate the results with larger and long-term follow-up. So these are the cases. I've done 1 level, I've done 2 levels, and even I have done 3-level deformity cases now. And I'm patient, as a surgeon I am, and as a patient, they both are happy. So my indications and contraindication for this procedure, my indications are wherever indirect decompression or a segmental deformity correction is possible. Whenever there is a collapsed disc space with sclerotic end plate, that is probably the most ideal case for me to do a Trans-Kambin fusion. Conducive anatomy at alpha S1, reasonably preserved segmental lordosis, especially at L4-5 S1. And my contraindications are segmental kyphosis. I have not tried my hands on segmental kyphosis. If I have a kyphotic patient, whether I will be able to restore significant lordosis or not, that maybe in the coming times I would see. I don't operate this procedure wherever there is a significant osteoporosis. So my borderline is anything less than -2.5 of DIGSA. I would want to refrain from this indirect decompression. And the adult deformity, where large lordosis restoration is needed or a osteotomy is in line, where I might want to defer from doing this procedure. Why this indication and contraindication? Because I'm still not reached to the level of proficiency like Professor Abbasi or some of my colleagues here. I'm still learning this technique. So I've restricted myself to safe indications and safe contraindication. To summarize, still on early phase of my learning curve, important to self-appraise before imbibing a new technique. Structured decision-making and continuous learning is the key. Ongoing data collection, larger follow-ups and collaborations with peers is necessary. And I invite you all to one of the premier event happening in our city, MISAPCon 2024. Thank you so much.
Wow.
Thank you very much, sir.
Well, thank you very much. That was a fantastic talk, Niraj. And
thank you.
I want to emphasize a few things that you said, and I wish everybody would adopt your way of getting to new technology, because that is truly a physician who has the patient's safety first in his priority. The way you are approaching new technology should be adopted by everybody. Now, I have a little nomenclature cleaning to do here, and I want to share my screen with everybody. Number one, obviously we talk about direct versus indirect decompression, and I think it is time for us literally have a new name instead of indirect decompression. And in my paper that I published, I call this physiologic decompression by anatomic restoration, or anatomic/physiologic decompression. Well, you and I, we don't have radiculopathy. We don't have radiculopathy because we are maintaining the disc base, we are maintaining the interpedicular space, and we have an anatomic decompression of that area. And more or less, I think in our surgery, what we call indirect decompression, we are trying to restore the anatomy to the time patient did not have radiculopathy or claudication. So practically, we are physiologically decompressing the area by anatomically correcting that collapse of the disc. Now, what's important, I want to emphasize to everybody, we don't have to correct that anatomy to the time patient was 20 years old. We just need to correct it to the time 2 years, 3 years before patients start having symptoms. Meaning that at the first, I myself overcorrected, but now I have learned that even increasing that interpedicular space 3 millimeter actually doubles the area of the foraminal and lateral recess, and is extremely efficient to provide anatomic/physiologic decompression, which we refer to indirect decompression. I think it's a time for our society to adopt the new name, because indirect has this connotation that there's something direct, something better way of doing that. Everybody who has done ACDF understands with ACDF, you're relying on indirect or anatomic decompression. So it is nothing indirect about it. It is an anatomic part of it, anatomic decompression, restoration that provide the benefit to the patient. The second thing is, as you have heard, we have many, many names for this procedure. And at the end of the day, it's just a nomenclature, and we shouldn't care much about that as long as people are doing that. But if you see my screen, we have to understand what's the difference between PLIF and TLIF, which is TLIF is truly transforaminal. Now, certainly, you can go at many different angles and be transforaminal, but I want to emphasize that the OLLIF, or oblique lateral posterior lumbar interbody fusion, is not a transforaminal. It is, you have to be literally in retroperitoneal space, as Dr. Kambin has described that. The reason he could put a urology endoscope and visualize everything is because he was in a space that there is a space, there is an actual space, it's a retroperitoneal space. So a true Trans-Kambin approach is that in a retroperitoneal space, anterior to transverse process, and there is a space that you actually can see with the endoscope. Now, the other approach is MIS direct lateral interbody fusion, which is practically more or less like MIS DLIF or XLIF, but we perform that in prone position, and that is the only difference. And now, should not be confused with OLLIF, which is oblique lateral interbody fusion anterior to psoas, which is we call as well OLLIF ATP. So I choose to use anatomical description. Certainly, if you use the endoscope, you can call it endolif. Some other people call it tubular or endoscopic TLIF and so on. But I think what's important to understand is anatomically, you are in the retroperitoneal space. You are preferably posterior to psoas, so you don't have to poke through psoas. And as well, even if you have to drill the lateral side of the facet, you're still approaching Trans-Kambin triangle and not intraforaminal space, and that's what makes it different. So we are at the end of the road, but the next talk has nothing to do with Kambin triangle. It's not a Trans-Kambin approach, but I think I'm very proud of that because I have one of my favorite people now going to talk about what else we do, and that is what makes us different. We don't just practice medicine. We like to change how medicine is practiced. And all of us, we know that, at least in the United States, 50% of what we do is documentation. We have been becoming, instead of provider doctors, we have become slave to documentation, to how we are going to practically document, and everybody else that helps us. And if I can tell you that there are better ways of practicing medicine, I'm hoping that the next presentation, it shows you what the future of spine practice is. So please, Jimmy, go ahead. I'm proud of what you and Misha have done. I'm really excited to share it with the bigger community.
Thank you so much, Dr. Abbasi. So I'm Jimmy Zhan. I'm the director of AI Lab here at Inspire Spine. And today I'm here to introduce our Smart Universal Resource Identifier System, SURI, artificial intelligence portfolio. So what problem are we trying to use AI to solve here at Inspire Spine? Here in this graph, it illustrates the number of healthcare bankruptcies over the past few years. There's been a consistent high number of facilities going out of business, with the significant surge in 2023 after the subsidies from COVID has stopped. The reason behind this high bankruptcy is the high human resource costs. So here in this graph, it shows the growth of physicians compared to medical administrators in the United States since the late 1990s. The number of administrators has increased significantly more than the number of physicians, the very people that are here providing care to patients. And that is the problem we are facing. To address these challenges, we introduced SURI, shortened for Smart Universal Resource Identifier, our artificial intelligence system designed to streamline operations and reduce unnecessary human resource costs, creating this blue line in the future and eliminate the need of human resource costs above it. So SURI's core philosophy is to transform multi-language unstructured input into a standardized structured output, which means human language into a structured output. SURI can convert conversation from over 60 different languages into a structured medical record in English in less than 60 seconds. In SURI's design, we emphasize standardization, accuracy, efficiency, and innovation. So what's the technology behind SURI? SURI leverage advanced natural language processing and automatic speech recognition. More importantly, it is tailored for healthcare professionals for the ease of use in life and in research. Like its name, SURI is a smart system that can utilize different kinds of tools to provide help in all different areas. As you can see here, we have coding, documentation, prior auth, and assistant. So how does Suri works? Suri simplifies documentation through a 5-step automated process: recording acquisition, text transcription, information concatenation, AI summarization, and physician verification. All doctors need to do is engage with patient. That's all. Suri takes care of all the rest of documentation. Before Suri, you have scribes to listen, summarize the conversation, and do other stuff. But now, Suri does all the job in a more accurate and efficient way. In this short video right here, it shows how Suri listens to human language and efficiently prepare all the information needed for a clinical visit. Suri is not only a tool to replace scribes, but it's a comprehensive AI-driven EMR and documentation system, organizing all the documents in one place for ease of access. All the documents from patients and doctors can be found easily with a clear label, showing important information at a glance. It significantly reduced the time needed when looking for an old document from hundreds and thousands of similar ones. You can draw up over 40,000 pages of documents that are mixed, and Suri will understand them, categorize them, assign them to the right person, to the right patient, right doctor, with the right category, and visualize them for you for the ease of search and use. As well, it is able to create timeline for patient care based on the provided documentation. And here in this video, it is a short demonstration on its documentation process. I'm using example of Dr. Abbasi's document, his CV. It's being read, connected to him through label, and in Suri, you simply drag and drop the document or even picture. Suri can read it, extract information like text from it, understand it, summarize it, and label it. You don't need an extra person to do any of the job in the future in the medical record system. So as a conclusion, at Inspire Spine, Suri offers consistently self-improving assistant to handle all details stably. By reducing redundant tests and eliminating unnecessary delays, Suri optimizes clinical workflows, allowing healthcare providers to focus on the main job, the patient care. Ultimately, Suri is designed to minimize the effort providers need to spend on administrative tasks, enabling them to devote more time and attention to patient care. And for healthcare practices, Suri, I would say, is the best solution to cut costs and promote efficiency. And that concludes my introduction to our artificial intelligence system, Suri. Thank you so much.
Thank you very much, Jimmy. That was a fantastic talk. But to finish our meeting, I need a volunteer. Maybe Dr. Anand can help me. Dr. Anand, are you there? I need a volunteer to play a patient, and I want to demonstrate the Suri's capacity for you. I need somebody who play a patient, and I'm going to be the doctor, and we will have a conversation, and I will show you step by step how Siri listen to our conversation, doesn't miss a beat, and create from our conversation a full medical record. But more importantly, Dr. Anand, I could as well have that conversation with you in German, in Farsi, in 60 other language, and still Suri would come and create a medical record for me. So Dr. Anand, do you have a few minutes for me to play a patient?
Dr. Abbasi, before leaving, can I have a word with you?
Yes, please.
Sir, I would like to host your meeting to India, and I will be privileged if you grant me this permission.
It would be my honor, sir.
So, thank you so much. It was my dream project that I wanted to be a host, and I take the permission from you to be a host, sir.
Thank you very much. I'm honored. Thank you very much, sir.
Obliged to you, sir. And I thank Anjam who brought me in contact with you. She's just like my sister. And just in minutes, I think I've lived a century, sir.
Thank you very much. Thank you very much, sir.
Obliged to you, sir.
God bless. Dr. Anand, I want to create a simulation and try to be as difficult of a patient that you can be, because I know when I have this with the patient, actually I go and talk to the patient, about 70% of the information patient provide to me are not consequential, not initially, really helpful. And so you will be a patient, to pick up one of your last 10 patients you have seen. You be that patient, I will be the doctor. We will simulate that we are together, and I'm going to examine you and show the capacity of the Suri to you. First, I'm going to share my screen. And I'm hoping you guys are able to see me. And I can just go, usually I can just go and talk to the Suri and say, Suri, start the medical record for patient 111555 in Pro Plaza. And then usually it actually opens it up and create this location here for us. And now practically you and I, we can start talking. So Mr. Anand, thank you for coming to us. Tell me, what's the problem? What brings you to me today?
Thank you, doctor, for seeing me. I'm really struggling here. I've got a lot of back pain. I'm really struggling to sleep. I can't walk. I got pain in my legs. You need to help me.
Oh, well,
I'm struggling.
Absolutely. Tell me, when did you start having the pain?
Oh, I've had it for a long time. It's just getting worse. I had it 20 years ago, but it comes and goes, but it's getting worse now. Last 2 years, it's getting really bad. I can't sleep. I can't sit. I can't rest. I can't walk. I'm really struggling. I have pain in the legs. I've got, numbness everywhere. My back is hurting.
No,
You
well,
have to help.
let's start with your back pain. 1 to 10, how bad is your back pain?
Oh, it's 10. It's definitely 10 out of 10.
Have you had any surgeries in the back or fall, accident, anything that is of importance? Any history of that?
Yes, I had a fall 10 years ago. I fell down the stairs, but it was there before. Now it's getting worse. I've had a few falls. My legs are getting a bit weak.
I see. And I'm actually looking at you. You're showing me your lower back. Let's talk about your leg pain. Is it right or left or both?
Oh, sometimes it's this one, sometimes it's that one. Now it's this one, but the other one's not working well either.
So both legs, and I see you're showing me your right leg. Now, in your right leg, show me exactly where the pain is, especially in the thigh. Is it in front, side, or back of the thigh?
It's front and the side.
Front
A
and
little
the
bit,
side.
little bit in the buttocks too.
Okay, so that's in what we call mostly correspond to L4 and L3. And it seems that, so how long have you had the leg pain, not the back pain?
Oh, it's been achy for a very long time, but it's getting worse. Maybe 2 years is getting worse in the legs.
And if you don't mind, I want to examine you now. I'm examining your legs, and I noticed that your hamstrings are weaker. They're not super weak, but I would call them 4 or 5, especially on the right side. Have you noticed that you have weaker hamstrings?
No, I don't know what they are, doctor.
Yeah, and as well, I see that you bringing the leg up. That is the muscle that is responsible for that. We call that iliopsoas. It seems that as well it's a little weaker. As well, I call it on the right side 4 out of 5. Your reflexes, I see that they're fine. Is there anything else we need to know, or I need to know before I want to look at the MRI from last week that you're bringing to me today? I want to look at that MRI. Anything else I'm missing I need to know?
I'm just struggling to bring my foot up a little bit and dragging. I've fallen over a few times.
Yes, and thank you for reminding me that. I see that as well. Your tibialis anterior is actually 4-. That is an exam that I'm noticing right now. Thank you for bringing to my attention. Now, have you done physical therapy, any injection, bracing? Have you done anything so far?
Yeah, I've had physiotherapy. I've seen lots of chiropractors. They've manipulated my back. I've had some osteopathy. I've had some injections in the government hospital. That's why I'm coming privately now. They've injected me lots of times. My legs are getting a bit thinner.
Yeah.
You need to help me.
I will. Let's look at the MRI. This MRI was done from your lumbar spine. Was done last week. Let's look at this. And when I'm looking at that, I see in your third disc from below, we call that L3-4, there is a large broad-based disc herniation. It's worse on the right, but I see a large part of the disc chronically coming out and pushing on the nerves on both sides. Obviously, the right side, I see it's worse. We call that L3-4 lateral recess and foraminal stenosis, more right than left. But as well, I see that the edge of the bone is really changed. In my jargon, we call that modic changes in the L3-4. That tells me this has been going on for a while. But as well, the spinal canal is very much narrowed. So here, these are the location that I see the narrowing. You see this picture, we call it T2. And in this T2 sequence, we usually see more white in this location, but now you're not able to see that because there's no space left. I'm not sure if that makes sense to you, but if you look at the level above, you see that in the level above, you see more white, where you don't see in the L3-4. Does that make sense to you, Mr. Anand?
Yes, it does. Yes, thank you.
Well, my option for you is obviously, to, first of all, I have to go and make sure that we have done all the non-surgical treatment. I will go back, look at all your documentation to see if you have done enough non-surgical treatment. But for purpose of talking about what to do, I like to get a CAT scan and I like to get X-rays from your entire spine and then measure some specific things. But I like to meet with you as soon as those images are done to come up with the most comprehensive kind of approach. Obviously, if we can look that recently we have done all the non-surgical treatment, then surgery would become an option. Regarding the surgery based on CAT scan, I'd like to talk about what are the options, decompression versus decompression with fusion. But I'm going to give you a package of information. Please go read about them. Let me do my homework. Let me get new films that show me the bone structure. And I'm hoping within a few weeks, you and I, we can meet and talk about the next step. Do you have any other question for me right now?
No, that sounds good. Thank you for helping me.
Thank you very much. Now, first of all, obviously, you were a very efficient patient. I wish all my patients were like you. I mean, I had no problem extracting information from you because for most of my patients, actually, they talk about the vacation with their sister-in-law and all the problem the sister-in-law had before they talk about actually the problem they had. And many of these patients, they as well bring lots of elements that has no bearing on our conversation. What Suri does, first, it does a one-to-one transcript in any language, any major language. And I want to show you the exact transcript of our conversation. This is the exact transcript of our conversation that Suri has prepared for us. And even every single thing that you and I talked is going to be here. And Suri is as well able to separate what you say versus what your wife says, what the doctor says, and so on. And obviously, this part is already much better than any computer that does transcription for you. But more importantly, now it extracts all the information in less than a minute. It has already made our medical record for us. So I don't have to go to the back room and start documenting things. Obviously, once it gets used to my habits, it does a better job to create a medical record that's more along what I am to do. And here it starts with the patient has severe back pain, difficulty sleeping. You mentioned that 3 times. So Suri understand that is a major symptoms for you. And then numbness, history of fall, and so on. What I noticed, I have scribes that they even miss certain things. Siri doesn't miss any important information. The symptoms are worsening over the last 2 years, bilateral leg pain, and so on. Obviously, I didn't ask you about your drinking habits and so on. So Siri is assuming it's normal. Regarding the weakness, here as you see, it put it in. And regarding the sensory, obviously, it has to get used to my habits a little more. But then the result of the MRI, it shows the herniation and so on and so forth, modic changes. And then it already has come not only with our diagnosis, but we are still working on that, but it actually codes it for us as well. It has to do a better job, but it's like any learning entity. We are still working on that. We are still at alpha test. We are not even at beta test for Suri. And then it creates as well as synopsis that I saw you at this state in Proplaza. You have severe back pain, bilateral leg pain, numbness, status post-fall. MRI of the lumbar spine was from last week with the disc disease, disc herniation, modic changes, weakness. And our plan is to do conservative treatment, get a CAT scan, X-ray, and then discuss our surgical options. Now, we could have talked 45 minutes in any other language and still would have created this note. And most important part is, this is like a scribe that learns every single time, works with you. And once it's really good, it's not going to leave you, go to you, have another job somewhere else. It'll stay with you for the rest of your life. And that enables you to have a learning system that helps you to optimize your practice. So this is way longer than I anticipated, but I hope that everybody had a good experience here. If I may, I like to ask the board members to stay on just to talk about the next step. But everybody else, thank you very much for joining us. It has been a pleasure, and it has been a great honor to have you all on this first inaugural Kambin Society meeting. Thank you very much. We may be able to answer one or two questions, but then I like for the members of the board to stay on to just talk about the next step. Okay. So let's see. We are going to now just wait a few minutes until everybody leaves. And then the idea is, just setting up the next Kambin Society meeting. My preference is if we can have 2 or 3 meetings a year. Hopefully, Dr. Agarwal has indicated that he has some avenues, maybe have a once a year or at least once every 2 year in-person meeting, which will foster our cooperation. I'm happy to discuss with all of you, get any suggestion, but I'm thinking probably we have a meeting in about a month in India, the Kambin Society meeting within the India's most important minimal invasive meeting. That is on 17. But I'm hoping that the next spring would be a good opportunity for us to have the next meeting. We have touched many subjects, and I think we can dive a little deeper. So, Dr. Imani, Professor Imani, thank you very much for joining us. And I'm hoping that you and I can continue our cooperation to bring the technology, truly the technology as well, back to my home country, Iran. We are open to have additional members that can help us to take us to the next step. So is there any suggestion from the board members regarding the next meeting?
I have one suggestion, sir. I think you often say that there is a lot to say because with minimal time, like 2 to 3 hours, you had urged to explain a lot, and the audience side had also questioned a lot. But it is a package of 8 or 10 big neurosurgeon, orthopedic and spine surgeon, and audience even get afraid to open their mouth that from where to start. I think as an audience point of view, if you show up every month at least once with your highly efficient team, because you are the pioneer, if you say yes, we are the team, we will make it possible, but please show up. Like it is easier to approach you and to know more about you and your procedure if you show up at least once in a month.
Well, once a month, we do have so-called Inspired Spine case conferences. That is always the first Saturday of the month between 10 and 12. That is already in existence. So we will share that link with all of you. So that is separate from Kambin Society meeting, but there's no reason there is no reason not to have them both. That meetings are practically people bring their cases. We talk about actual cases every first Saturday of the month between 10 and 11 a.m. Central US Standard Time. You please take ownership of that. And, you know, if people want to bring cases in, they're always welcome to bring the cases in. We have lots of experts that we put the case on, we put it to discussion, we come up with ideas, and as well it's a venue that we bring our complicated cases, we bring our complication for benefit of everybody. So definitely we are happy to as well invite everybody to our monthly case conferences, which we can rebrand as Kambin Society Case Conference. But that has been going on, by the way, for last 6 years. For last 6 years, every first Saturday of the month, we meet together and discuss cases.
And another suggestion is, sir, here everybody speak about their success and how they overcome the difficulties, like how Professor Imani also said that in Iran it was so difficult for him, or our Indian colleagues also said their difficulties and the complication and how they success. What about the difficulties? What about the failure? Because I believe one learn when someone expose their failure, and here is 10, 12 heads are here, they can help by solving. If they show up that I was stuck at that position, I had a blood loss, here everybody is saying I have 10 ml blood loss, I have no blood loss. What about if I operate and if I have more than 100 ml blood loss, and nobody's talking about that? So I would like to make it more like mortality, morbidity case report, that failure is appreciated, and please talk about your complications.
That is exactly what these monthly conferences are about. Cases that are difficult, that are complicated, that not everything goes toward the direction we are looking for. And that is exactly why we have been doing it for the last, actually since 2017, 2018, we have been doing it monthly. So all those cases are welcome exactly in that meeting. Well,
okay, and looking forward to get the link.
Yes, yes. We will make sure we share it with you and through you with everybody else. Okay?
Okay.
Okay. Is there any question we need to answer before we conclude the Kambin Society inaugural meeting? Then, if there is no question, then I would like to thank everybody. Please enjoy the rest of your weekend, and hopefully we see you soon. Thank you, everybody.
Thank you, Hamid John.
Thank you.